Good morning.
Good morning.
Feeling better?
Yes, yes. I got my eye drops changed.
Okay.
So it's the pressure has been down. So
Okay, good.
yeah, so hopefully it stays down. But I'm going to go back this evening to just a quick check again.
Okay, good. I was wondering if all this screen time has an impact. Um,
Yes, yes, I think. And I'm also going to buy a screen, my my
your
one of my
blockers.
yes, exactly, for all my screens. So I think it's
Yeah.
also because I'm way too much on screen too. That's another thing.
Especially after that conference. It was
Right.
a
Yeah.
lot.
Yeah.
So I received a text from Marcelo and from Lisa that they're both going to be about 5 to 10 minutes late.
Okay.
Are you okay with waiting?
Yes.
Okay, then let's do that. And I'm gonna go off screen because
I'm going to go off screen. I'm going to grab some coffee if
good.
that's okay.
Do
Yeah.
that. I'll see you in 10 minutes. Good morning, Lisa.
Good morning. How you doing?
I'm good. Thank you so much for your text. Marcelo text as well. And so Alice asked if she could step away to get a cup of coffee. So I said
Oh,
that's
okay.
so we're all
Yeah, sorry about that.
no problem. gonna um record something, so I'm just going on mute.
Okay.
Feel like the month has flown by.
Yeah, super busy.
Yeah, well, I think the usual busy, but just it seems like time is just moving quicker. I don't know what
Yeah.
this is, that season though that that many of us as pastors are accustomed to, and with the Holy Week and all of that.
Yeah.
One of my self-care things is to hydrate. I forget to drink water. Are you
Yeah, me
good
too.
with keeping yourself hydrated? No.
With the wrong things. Sweet tea, so not sodas, but sweet tea mostly, and coffee.
How do you take your coffee?
Creamer, sugar, um, or evaporated milk, canned milk.
You're right. Not the best.
Not good, is it?
Black would help, but that's not how we take it. Hi, Marcelo.
Hi, good morning, everyone.
Good
Hey,
morning.
Marcella. Morning.
I did share with Alice that both you and Lisa were going to be running a little late today, so she asked to step away to get a cup of coffee. So I'm sure she'll be back shortly. She was here at
Okay,
10. So
cool.
let's just give her a couple of moments. And we have some flexibility because I'm going to start with the conversation about the final evaluation
Okay.
and address any questions around that before we go into our verbatims. So we should be fine with our time management today. Ooh, that was cold. Makes me want a hot cup of coffee.
See? Yep.
Mm. Marcelo, just before you came on, Lisa and I were talking about the challenge of being hydrated. And it's a growing edge for me in my self-care. To one of the nurse practitioners I was working with this week pointed out to me, if your lips are white and dry, you are way low on fluids. And so you really have to do something to catch up. So I'm trying today, especially to get some fluids. How are you on hydration? Do you hydrate as you take your 10,000 steps?
Yes. Yesterday I walk more around the 6 miles.
Oh, wow.
Yeah.
That's more than 10,000.
Yeah, it's 15,000, I think.
Wow.
Yeah.
Do you
Because
carry water?
yes, I think because yesterday I I went to my wife to the mall.
Oh. Yeah, the mall will do that to you.
Yeah.
Yeah.
Let me see.
Well, thank you,
Morning,
everyone.
Lisa and Marcelo.
Hey,
Good
morning.
morning.
I did share with them. You were here earlier, Alice, and so I'm glad we're all here. Let's check in a little bit. How have you arrived? How have you arrived? I've already shared I arrived dehydrated, so I'm working on it. How have
Just
you arrived?
rushed.
Rushed?
It's been a busy week.
I'm
How about you,
grateful.
Marcelo? You're traveling. I thank you for pulling over, by the way.
Yeah, I'm here in the border. My son is walk to in San Diego. Is the border airport is together pass to the border for here for Tijuana for walk.
Ah, okay.
Yeah.
So literally, where are you sitting? Where are you parked?
I am in parking lot in the airport. The
Wow.
no, it's San Diego is other. San Diego is two airport. It's San Diego International. This is cross border express.
Yeah, that's
Yeah.
for express flights.
Yeah.
Okay. Well, Alice, I don't see the coffee, but I guess you got it. How have you arrived now?
Mm.
Mhm.
Not even a small cup. All right. There you go. Thank you, Marcelo. Bring in the water.
No, I arrived grateful. I've been really down and low this week. Actually, I've not taught any class this week, so I'm grateful today. I feel a lot better. My eyes, for once, my head is not aching because of high pressure. So I arrived grateful. So
That is good. Good. Well, I am grateful that we are here, and we had flexibility this morning because I'm going to simply go over the final evaluations, which we don't begin May 2nd is when we have our first bunch. So I'm going to share my screen and go through what's in your handbook, and just expound on those directions. So if you want to turn to your handbook, feel free to do that. Let me pull it up real quick. And can't believe it. We are talking about final evaluations. Okay, there it is. I'll make it a little larger. Are you able to see that? How's that?
Mm-hmm.
Yes.
Thank you.
Yes.
So it's in your handbook, section 512. This is around page 128, because sometimes the pages are a little off. You want to make sure, Alice and Marcelo, that you are using final evaluation form 1A.
Okay.
And Lisa, you will make sure you're using final evaluation 1B.
Okay.
So don't make a mistake and get the wrong form. It does matter because the outcomes and indicators are listed accordingly. This part, when you fill it in, it says ACPE certified educator. Please add the word candidate that I have in blue and then list my name. And if you do titles, then give everyone a title. If you don't do titles like Reverend or Doctor, then simply put our name, and I'm fine with you just putting our name. Then under it, you'll have to add the line, please, supervising certified educator Rodney Seeger. If you don't add it, it's not the end of the world, but it would be helpful if you would, because that's not on your form in your handbook. And obviously the handbook says 2024, so you'll put in the correct dates of the unit. And if you don't recall, it's right on your syllabus. Now, if I discover I had a question into Joseph, let me see if he replied.
So, excuse me. My supervisor certificate educator is you.
Your ACPE certified educator, add the word candidate and then
Okay.
put my name.
Okay, candidate is your name?
And my name, Donna Allen.
Okay.
Yes. And
You will
then
share this with us, right?
I think there is a way for me to pull this out the handbook and share just these pages. I can, I'll try to figure it out. I think there's a way to just pull out these 2 pages. And if this part in blue here with Rodney Seeger isn't added, I don't think it's a big problem, but I think it would be helpful. Okay, so again, this is in your handbook, and I will, as Alice has asked, I will also email these particular pages to you. So the first part of the final evaluation is to find a symbol that represents your CPE journey for the unit. So when I did my final evaluation as a CPE student, my first symbol was of a painting of a woman in a posture of prayer. And she had doves, descending and ascending, coming to her and going away from her. And it was my symbol of my CPE journey and the way in which prayer was such a big part of how I got through that first unit. I actually think we had to do 2, but be that as it may. So that was a symbol. So it's very simple, some sort of symbol or image. that represents your CPE journey for this unit. And then just write 1 or 2 paragraphs about what that symbol means to you. Now, in the handbook, it says 1 or 2 paragraphs to describe the symbol that best represents your journey for this unit, fewer than 15 lines. I'm not going to count the lines, so the sentences or the lines is not so critical as to give you a number so that you don't think it has to be longer than it needs to be. You should be able to succinctly explain how that symbol captures your CPE journey. You will be invited at graduation to share your symbol and those few sentences that explain how that symbol represents your journey with the entire CPE group, all the educators, and with board members. So you want it to be very succinct and specific, and you'll present it here in our group first, and you'll get feedback from us on whether or not we understood it, and if you want to make any adjustments, you can. And any questions on that? So a symbol, an image that represents your CPE journey for this unit. Any questions or comments? And Lisa, knowing that, you know, you've done this, feel free to chime in with anything that you found helpful when you did this assignment. Okay, then the next, okay, then the
No,
next
go ahead.
part, section 1 is about your learning contract. So you want to go back and get the learning contract that you submitted at the beginning of the unit, and you presented it here in group. You got feedback on it in group. Go back and get that learning contract, and you want to address each of your learning goals separately. So you want to take your learning goal number 1. I made great progress on this learning goal, for example, and then give a couple of quick examples. And I've achieved this goal. Goal number 2, I haven't made as much progress on this goal. Here's some of the things I have done, and here's areas of growth that I've identified. So I'm just making up the words, but you want to take each of your goals that you already submitted from your learning contract and now go through, just cut and paste them into this document if you'd like, and describe your progress in achieving your goals. So none of you, to my recollection, have a goal that you have not made progress on. So you'll just describe succinctly the progress you've made on your goal. Any question on that?
No.
Okay. Then section 2. This is the fun part. You're going to look at all those outcomes. And now the weekly tracking that you've been doing with your indicators and outcomes makes this so easy because you already have this information documented. So you're simply going to go through for each indicator and evaluate yourself by simply marking an X. So you are either going to be, I'm not engaging this indicator at all, put an X in that box right there. Or it'll be that I need improvement, or I meet expectations, or I've exceeded expectations on this learning goal. So you literally would just go into the box and put an X in your self-evaluation of how you have done with this indicator. Then under the box, after you have made your X, create a little space, let me take that back because I don't want you to think you got to create a box. You have to create another box, go down to the next indicator in your document. It's a Word document. Create some space. And in this area right here, can you see my cursor? Am I using a pointer? This
we
area,
see it.
right there you go. This area right in here, you're going to write a paragraph that gives a couple of examples of why you have evaluated yourself the way that you did. Okay, so it's just a short paragraph on why you evaluated yourself. So it says provide a narrative at the end of each category. So it's a few sentences that says, hey, I've achieved this with my narrative history. And then you just give a couple of succinct sentences, description on why you evaluated yourself as exceeding expectations in your ability to identify formative and transformative experiences in your narrative history and the significance to your spiritual journey. So again, it's going to be no more than a paragraph. And it'll be right after the indicator. So you're going to do this for every indicator. And again, the easiest way to create the space you need in between to enter your document, I don't know how to clear all that I just did, is to simply go to the next indicator and just push enter and push it down. And then you can actually add your text right in here. You'll be able to type it right in. And again, it's only a paragraph. You need to do that for each one. Any questions? And so you might ask me, can I simply cut and paste from my tracking document? Yes, you can. You can just simply cut and paste. And it would be not the whole, not every category. What you would be cutting and pasting would be that last box on your outcome indicator tracking document where you show you, what's the language we use? Evidence of your progress. That's what you would cut and paste from and just put it in here. I evaluate myself as meeting expectations for narrative history because, and then you just cut and paste that in.
Oh, that is perfect.
Good, right? All right.
You have to rethink. I was like,
You sure don't.
Do 25 of those.
Because you've already thought about it and we've talked about them. So you've already had some feedback and dialogue and reflection on them. Now the heart of your reflection is whether or not you feel you met expectations, you need some more improvement, or you've exceeded expectations. Okay, you're going to do that for every indicator. What is sometimes done at the end of the whole section, like here, spiritual vibe, are some additional comments that I don't need you to make a summary statement. If you do the little cut and paste all along, you're fine. So you're going to see students' comments. Don't worry about that. That's what I just described to you. So don't think you have to make additional comments. Okay. And I highlighted because I said that could be confusing when you see it. Because it's using the word student comment like you have to come up with something new. You don't. Say, hey, I evaluate myself as meets expectations because I've demonstrated this competency, and then cut and paste in the way you demonstrated your progress.
So it's it's only the indicators that represent us.
No, you have to do it for every single indicator for your level.
Oh yeah, but it's, for example, it's level 1A, but we have 25 indicators. So
Yes.
I put in every.
Yes. So if there's an indicator that you have not addressed, you would mark not engaging. And your simple statement would be, I have not engaged this indicator at all in the unit.
So we are required to engage, right?
Correct. You are required to engage. Let me change that. You are encouraged to engage every single outcome and indicator in the unit. In order to get credit for the unit, you have to achieve at the level of 80%. But, okay. But as you know, as we're going through and when we talk about the indicators in IS, I'm always encouraging you to get the ones you haven't accomplished yet. So don't worry about trying to create something that isn't there. If you haven't addressed an indicator, you simply mark, I've not yet engage this. Just because you haven't engaged one doesn't mean you won't get credit for the unit. When you present this to us in our group, it'll just be our group, you may say, I'm not engaged this at all. But then the feedback that you will get from your peers might be, actually, this is how I've seen you engage this.
Oh,
And then you can go, oh, I hadn't thought about that. And then you're able to change the document and submit your final evaluation after you've had feedback and conversation from your peers and your educator.
mm.
Okay?
Okay.
So it's important. Don't try to create. Do your self-assessment and allows us to have some engagement with you. And again, you don't have to have all of them in order to pass the unit. You have to achieve at 80%. And if you want to see the specific breakdowns, it's in the handbook. Joseph lays it out so you can see exactly what it is. But any other questions about that?
What day is this? We're gonna do this?
We start May 2nd. I think you signed up to be, I don't know if you're one of the first people or not. I apologize. I can't put my hand on that particular.
Oh, that's okay.
But
I
it's
just wanted the date. Yeah.
May
Okay.
2nd is when we
Okay.
begin doing these. And we have 2 class sessions, May 2nd and May 9th.
Yeah, I think I remember being in the first one. Okay.
Okay, cool. You got it. All right. So you're going to go through all of the indicators. I'm just going to go through that section. It's all laid out. Mark the X, create the space, do what you got to do for all of them. Allow me to just scroll quickly through it. And so Marcelo and Alice, when it's all said and done, you get to the end. This part right here, reflection on relationships. So you're going to reflect on your relationships in this section. You're going to identify your relationship with your supervisor. I want to separate it out. Or your educator. Let's see if I can do it. So your peer group, don't leave anybody out in your peer group. Your relationship with each member of the peer group. So you're going to have a comment for Alice. You're going to have a comment for Marcelo. You're going to have a comment for Lisa, for each person.
Mm-hmm.
And then for each person, identify their strengths and growing edges, in their role as your peer as a spiritual care provider. Well, what do I know about their strengths and growing edges as a spiritual care provider? You have experienced their verbatims. You've experienced their image of the writing they did of themselves as a spiritual care provider. You've experienced their feedback in group. You've experienced their mid-unit evaluation. So you actually have a lot of resources. You've experienced them in IPG, where you can assess the strengths and growing edges as a spiritual care provider for every member of the group. And that includes me. So when you comment on your relationship with me, you can also include IS time. And it's just your strengths and growing edges. And I know the growing edges can be difficult to identify, but try for each person to identify. As you know, it's one of your outcomes and indicators. So if you accomplish it here, you may be able to say, I met this indicator in my evaluation and feedback in the final evaluation. No one met it in the mid-unit evaluation because you didn't identify a strength and a growing edge for everyone. Because it is not acceptable to say they have no growing edges. They actually do. But you got to think through, what are their growing edges? Okay. And it doesn't have to be, it says edges. It may just be one. Doesn't have to be plural. Okay.
Is it allowable to ask each one, please, what is your growing edge?
No, it is not, because but I appreciate
you tried.
I appreciate you. Okay. And one of the things I'm going to share this, it was a growing edge that was given to me early in the CEC process. And the person said, and I may have shared this, I apologize, that the certified educator evaluated me as not smiling enough. And I had all sorts of dynamics that made me pause. First of all, it was a man making this assessment that I haven't smiled enough. And there were some other cultural differences. And so I really took initially I was like, "Pfft." And then I thought, wait a minute, let me think about that. And I thought about it. I took it to consultation to my peers and thought about it with them. And I discovered, you know what? I wasn't smiling enough. And in part, I wasn't smiling enough because I came to learn when I reflected on that growing edge that I was nervous. So I wasn't smiling. I was very serious. I was trying to stay focused. I also was aware I wasn't smiling because I wanted to be taken seriously as an educator. And so I thought if I was too smiley, if you will, that I wouldn't be taken seriously. And I realized, oh, that's some of my academia issues. Because in academia, as an instructor in the seminary classroom, I am not standing in front of the class smiling a whole lot, right? So it was seemingly an odd growing edge, but it had so much information in it for me.
Mhm.
So it doesn't have to be something deep. Often the person, when getting the feedback, can reflect and take it even further than you sharing may even be aware of. Again, we're going to share it in group. And so let's say you said to me, you do not smile enough. I'm right here in the group. When you finish your mid unit, I'm going to come back. I may come back and say to you, forget you. I smile plenty. And you come back, no, you don't. And then somebody else chimes in, she's right. You don't smile enough. All of a sudden, we're having a discussion. And right in your presenting of your final evaluation, there may be some new insights, and you're able to edit your document and say, you know what, I said doesn't smile enough. What I really realized what I was trying to say is blah, 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 blah. Okay. So find something for everyone and trust the group and us enough to take what sounds like negative criticism, and it isn't, it's constructive criticism. Trust us to take it and learn from it, because that's what we've been doing in this group the whole time, learning from one another. So trust the group and the dynamic that you can identify a growing edge, and we will engage you. That's what I'm trusting. Okay. Then you're going to sign it. Probably the most difficult part. People are like, how am I going to sign this document electronically? Lisa, you have any insight for them on how to electronically sign this document?
I use when when you can go up there, it says draw. I use that, and I just use, with that same like that thing you were using there. I use
Oh, you
when
use
it's
draw. Got
yeah,
it.
that's how I do mine.
To the best. Ooh, good for you. So you just draw your, okay.
Yep.
All right. There you
I
go,
have-
guys.
I
have-
use the
have
I use the
signing.
I use the ink part, the sharp one.
This
One
one?
of those. Yeah,
And then you just take it and you draw your name.
yeah.
And it looks real cute. Okay. I like that. I have my signature on a Word document, so I just cut and paste my signature, but I like that.
What about Adobe? I do have filling signature for Adobe. It's
There you
PDF.
go. That's right. You can take the Adobe, save
Yeah,
it
I
as
have that.
Adobe and have it.
I have that. That's how I sign most things nowadays.
Good. Very good. So I want to be clear in this section. You're going to make sure you comment on your role in your peer group. Don't forget to leave yourself out. Your relationship with each member of the peer group, and your assessment of their strengths and growing edges. Don't leave yourself out and only comment on everyone. You're assessing your role in your group, your peer group as well. And it could be things like in the beginning of the peer group, I did not offer much feedback. As the group progressed, I offered more feedback. In the beginning of the group, when verbatims were presented, I never volunteered to do anything. But as the group progressed, I got more comfortable and I would be the first person to volunteer to read for verbatim, whatever it might be. Okay. Any questions on the final evaluation? I hope Marcel, there you go, Marcel. Any questions on that?
Is it okay to like I've done something for some retreat where we did symbols, which I really like the symbol. I like the symbol, for instance, of the clay jar, which for me really represents 2 Corinthians 4:7. That is very unique, and I've been feeling it all through. So you can use symbol you've used for something else, right?
You can use a symbol that you've used for something else if it is an accurate
Okay.
representation of your CPE.
Right.
Yes.
Right. Absolutely.
Yes.
I'm thinking
Absolutely.
fitting. Yeah.
Great. There's no problem for that.
Okay.
Marcelo, I think you're trying to, you're breaking up.
Just the next class. But now there are no
Marcelo, your audio is such that we can't understand you. I don't know if there's anything I can do on my.
we can ask next class.
We can hear you, but we can't understand you. You might have to log out and log back in. Because it just sounds like a delay, but right now it's such that we can't understand you. Do you have a question, Marcella?
Yes. We have class. The last class is in April 25.
I still can't understand you. So you could try logging out and log back in, or you could use the chat. So if you go to the chat, let me open it up. Yes, you sure can ask in the next class session. Yes. I want to, I don't think I've left anything out. I had notes and oh, here they are. Let me make sure.
Marcella's asking you a question
Good, yeah.
in the chat.
You have only one class, April 25th. Let me see what you're seeing.
Because we're out next week, right, for Easter or Holy Week.
What do we call it? Spring break.
Yeah, yeah.
And our last class session is May 9th. Oh, good. I think maybe he'll log out and come back. We already know, and we have made the adjustment that we needed to, that Alice is going to be away April 25th. And we're going to make sure to record that presentation.
Thank you.
And as you know, I've shared it with you before, where I'm slightly over in the class time hours, so you can miss a session. I'll give you, if you need it, I'll give you some sort of a makeup assignment. But when it's occurring this late in the semester, it's not in the unit, it's not necessary. When you miss early in the unit, just in case you might have to miss again due to sickness or something unforeseen, I ask for you to do a makeup so you don't run out of time. But we're at the end and you're fine.
Thank you.
Okay, so
Alice, I didn't get your verbatim.
I did. It's attached to yours.
You got the right Lisa? Because I didn't get your last one either. Now unless it went to my junk mail, I'll have to look.
I sent it on Wednesday, and I literally on yours, I just forward to everyone.
what email do you have for Lisa?
I actually just use her email. She had sent hers in the morning, and then
you replied.
I just replied there and sent to everyone. Did you get it, Donna?
Yes, I did.
Let me see.
Alice is going to take a look at her. Lisa says she's going to look at her junk mail.
Let me just make sure that, yeah, because I use your link. I didn't just create a new one. I just use yours. Lisa, it was 2 days ago, sent at
10:32 p.m. I do see your correct email address listed.
Okay.
You try forwarding?
I couldn't.
You want me
Yeah, if you
to
don't.
send to you?
Okay, I'll do it right now. I'll forward it to you.
Oh, okay, thank you.
Okay, I just did it.
Thank you.
You're welcome. All right, so I hope that answered your question, Marcelo. So we do meet our next week is spring break, right? I don't know.
We still submit our weekly reflection and indicators, right?
Yes, please do. You continue to send in those documents each week. What is today? Today is the 11th. Next week is our spring break. Then our next class session is April 25th. Then May 2nd, which is when you're presenting those final evaluations. I thought it was helpful not to come right back from spring break and have to do it. And then May 9th, if we haven't covered all of them on May 2nd. So, and then we're done. May 19th is the graduation, where you will likely have an opportunity to share your symbol. That could change, but I'd rather you be prepared and not have to share it than not prepared and they call on you.
May 19th.
May 14th is graduation.
Oh, I thought okay.
Week
May 4th.
19, May 14th. Thank you. I may have
Oh,
said it wrong. I may have said it wrong. Thank you. Then week 19, which is May 16th, and week 20, which is May 19th, we're not meeting, but you're still submitting. I mean, there's no classwork. So that those are the only 2 weeks where you won't have to do any classwork. You don't have to submit the reflection or any of that. So your reflections stop with week 18. Unless
So
you
graduation is
need to
May,
catch
May
up.
19, May 14.
It is on a Wednesday, May 14th.
Ha ha ha! I'm in
And
trouble.
if you're not able to attend, just communicate that you're not able to attend. That's fine. We understand.
Oh, because I just accepted to be a respondent to a conference paper.
No
You
problem.
just check. Oh my God, what
Check
happened?
your calendar. If that's the case, Alice, just send me an email and I'll send it to Joseph, letting him know you're not going to be present. And then he may send you an evaluation form and you'll simply do the evaluation form.
Okay, let me see.
Okay.
Oh, no, no, no. It's May 13th.
Okay, Marcelo's removing his camera so his signal is strong, but he's
It's
listening.
the conference response.
Oh, good. Okay.
I'm here.
I will mute him. Okay, good.
Yeah, I'll be here. It is May. The conference is May 13th.
Wonderful.
So
Okay, good.
I'll
So we
be.
will have you. All right. So any other questions or comments? I'd like us to take a short break before we do our first verbatim, and it would be great to know who's going to go first.
no, don't even try it, Alice.
Okay, no problem. I'm going to go.
Okay, then let's take a break. I will see
I
you.
will have to change the computer. I will just go downstairs and change computer. This computer, it shows is no, it might, oh my, no, it's always something's wrong with this thing. Anyway, we'll see.
Okay, so come back at 5 minutes after the hour. So it's 5 minutes after 11 here. So 5 minutes after 2 for you, Lisa. I want Alice to have plenty of time to work on the computer. See you shortly.
Okay.
Hi, everyone.
Hello. We have break 10 minutes.
I see. Okay.
Good afternoon, or really it's still morning. Good morning.
Hello.
We have a couple more students one more student who's coming back, and Marcelo, who's one of our students, he needed to travel. So he's doing his best to maintain his signal. So he may turn his camera off to strengthen his signal so that he can hear. I am so glad you were able to join us. I didn't know if you were going to make it today. And so I'm so glad you're here. So Alice, you're off the hook for a second. You can stop your screen.
Okay, perfect.
You're perfect, right? And we are so blessed to have a presentation today for this portion of our time together. Lisa, Marcelo, and Alice are all in clinical pastoral education, training to be chaplains. They are in different settings. Marcelo's in a hospital setting. Lisa is in a church setting, and Alice is in a church setting, but also a community setting. They're all interested in being in a healthcare setting at some point. And of course, as you know, I'm at Altabate Summit Medical Center. So welcome. Will you take a moment to introduce yourself and then take it away? I'm so glad you could make it.
Yeah, I'm very glad to be here. It's nice to talk to people outside of my world, and
Yes.
I hope that this is of relevance. So I'm Nandita. I'm a neonatologist at Altabates Summit Hospital in Berkeley. I also work at the UCSF Children's Hospital in Oakland. And I was asked to come and give you guys a talk that I recently gave at the bereavement workshop that is held at Alta Bates. I am going to be talking about infants born with a genetic diagnosis called trisomy 13 and 18. I'm not sure how familiar you guys are with this diagnosis, but I'm happy to talk about it in a little bit more detail, and I hope it is of relevance. And this is, this is a very specific disease that tends to affect newborns, generally is diagnosed prenatally, but not always. And infants with this diagnosis typically have a short lifespan and also have significant neurodevelopmental problems in that short lifespan. So there is a lot of debate around caring for these infants, and I'm hoping that there will be concepts in this talk that would be applicable for you guys in other aspects of um, caring for babies or children or even those that are older. So
Does-
please, is that
Yes,
okay?
please feel free to ask questions. And does anyone need
Yes.
a little bit more of a definition? Or we okay?
Yeah.
Okay.
Okay. Yeah. Please feel free to stop me, and if it gets too if I go into too much of the weeds, then please tell me that this is more than what is helpful for this moment. So I'm happy to make it as you know, whatever is needed for today. Okay, so I'm gonna go ahead and share my screen if that's okay.
Yes, please do.
Okay. Can everybody see my screen?
Yes, it looks good.
Yes.
Okay, great. All right, so this is my topic, as I mentioned earlier, evolving landscape in the care of infants with trisomy 13 and 18, and I'll tell you what's evolving in a second. So my hope is in the next 45 minutes or so to be able to give you guys a little bit of the historical context and how these infants were managed in the past, and then to look at more recent evidence on outcomes and approach in the care of these infants, to look at some papers that have been able to describe parental perspectives on lives with infants with this condition, and then to make some recommendations on how we care for these infants moving forward. So trisomy 13 and 18 is the focus, like I said. Of these two, trisomy 18 is more common. It's the second most common autosomal trisomy. Trisomy 13 is the third most common. You guys must have heard about trisomy 21 or Down syndrome. That is the most common trisomy. So in terms of prevalence, trisomy 21 followed by 18, and the most rare of these three is trisomy 13. And I think we can skip the live born prevalence. Talking about why these infants die, about 40 to 60% of fetuses diagnosed with trisomy 13 or 18 are electively terminated. So when mothers hear of this diagnosis through their ultrasounds or their non-invasive prenatal testing, and if they find this out, a lot of women choose to electively terminate. And sometimes if they don't electively terminate, they spontaneously, unfortunately, terminate, or the baby gets aborted. Of the infants who do make it to life or who end up having a live birth, the major causes of death are central apnea, which means that babies stop breathing, cardiac failure or heart failure, and respiratory failure, so failure of their breathing, the respiratory system, and upper airway obstruction. And likely it is a combination of these factors, including decisions regarding the direction of care or intensive care. So what is the debate? Why are we having this dialogue? And there are conferences around this right now, and ethicists and neonatologists and cardiologists and surgeons are all discussing this topic, quite actively in the last few years. And why is that? And that is because of this somewhat of a dilemma amongst parents and healthcare professionals, that is it appropriate to provide painful, invasive, and expensive interventions to infants with this diagnosis when the only possible outcome is death or life with significant neurodevelopmental impairment? So there are many who feel that the potential experience of pain and suffering is too much. They feel that there is a perception of uniform lethality, that they all die. And I will talk about that more, about how that perception is not so accurate anymore, but many still hold on to that perception that it is a lethal diagnosis, and so care is futile. But if you look at it from a true ethical lens, how do you define care as being futile? So care is considered to be futile if it's not meeting the goals. But who is defining these goals is the question. Is it parents who are defining these goals, or is it the physician? And so is it the physician's goals that are not being met, or is it the parent's goal? There's also the argument that many make of allocation of scarce resources, that is it appropriate to provide these expensive resources to these infants given their outcome? But then from a justice lens and ethics, similar diagnosis should be treated similarly. So, there are many who make the argument that if we are utilizing the argument of scarce resources for these infants, there are so many other diagnoses that this could be applied to. But are we truly uniformly doing that? Are we being equitable in how we think about scarce resources, or are we biased towards a specific diagnosis? And so there are those who believe in the value of preserving life, and that cognitive impairment does not necessarily lead to pain or suffering, and that discomfort of many interventions is temporary, and that surgical procedures have actually improved outcomes. And so to give you guys some historical context, that non-treatment, so we're talking about trisomy 21 now, not 18, 13, but 21. Non-treatment of trisomy 21 was routine in the 50s and 60s, so they were not treated. And this was supported by leading pediatricians and theologians. And I want to quote this statement, which I always preface with saying that it makes me flinch a little bit when I read this. But I think it's important to read it just to give us a context of, where we have started from. So in the 1968, this is a famous pediatrician who made this statement that people have no reason to feel guilty about putting a Down syndrome baby away, whether it's put away in the sense of hidden in a sanitarium or in a more responsible, lethal sense. It is sad, yes, dreadful, but it carries no guilt. True guilt arises only from an offense against a person, and a Downs is not a person. It makes me queasy to read this statement, but just, this is where we were in 1968 and how we treated infants with trisomy 21, which I'm assuming, and I don't know if I should, that most of you are aware that that is completely changed in today's times. In trisomy, infants with trisomy 21 are given full care and have no limitations and there is no conflict anymore. We treat them like we would any other baby, and there is no bias against that population. However, there is continued difference in perception for infants with trisomy 13 and 18. And we'll talk more, but there is reason for why. So in 1982, just to give context on Down syndrome, and that was 1960s. So in 1980s, there was a well-publicized case of a newborn with Down syndrome known as Baby Doe, whose parents chose not to pursue surgery, and that is what led to change in regulations for trisomy 21. By the 1990s, discussions on selective non-treatment of newborns with serious anomalies began to focus on newborns with trisomy 13 and 18. In 2005, AAP, which, as many of you know, the American Academy of Pediatrics, which is the national board of pediatricians, in their resuscitation guidelines, they included trisomy 13 and 18 in the list of conditions for which resuscitation is not indicated. In 2006, trisomy 18 was removed from the above. In 2010, AHA, which is the American Heart Association, they made similar recommendations on the basis of unacceptably high morbidity. However, there was a simultaneous shift in neonatologists' attitudes regarding delivery room resuscitation, with 44% of providers reporting that they would consider initiating resuscitation in these infants, even with a heart disease. One of the reasons for this shift has been parental advocacy, as well as physicians and ethicists arguing that at least for some of these infants and children, lethality is a self-fulfilling prophecy by the medical community. And I really, want to hone into that. And, a self-fulfilling prophecy is one where we make a prophecy that infants with this diagnosis don't live. And because we have made that prophecy, we don't try to treat them. And when we don't try to treat them, they do die. And so we have been able to continue this self-fulfilling prophecy in the medical community, or at least we had in the past. More and more interventions are now available in medicine that are improving survival. But with increased survival comes increased risk. So the question then is, should we intervene? And ideally, I was always taught that good ethics starts with good data. So ideally, you want to use data to answer this question. However, the data we look at can also be reflective of our values as an individual and as a group. And so we have to be careful about falling into the trap of self-fulfilling prophecies and careful about our own biases as we look at the data. So this is more recent in terms of what is their survival in their first year. So as you can see, about half of these infants don't survive longer than a week. About 11 to 44% survive the first month, and 1/3 survive 3 months. And about 10% survive 1 year. So the numbers are, their survival is really not great in terms of overall data that is available now. But just to give you context, this was a paper that was published in Japan. I think this is from 2004 or 2006. So it was a while back. And just to give you guys context, that in Japan, these infants, this was a case series of 24 infants with trisomy 18 who were given treatment, because in 2006 in the United States we were not offering treatment to these patients. So in Japan, when they did offer intensive care to these infants, what they found was that survival rate at age 1 week was 88% in these 24 patients. At 1 month was 83% and was 25% at 1 year. So just to give you guys context on where things were at in Japan 20 years back. But one caveat to this study is you have to always keep in mind is that trisomy 13 and 18 is a very heterogeneous disease. There are some whose heart is involved. There's some whose heart and brain is involved. There are some whose heart, brain, abdomen, extremities, all is involved. So it's a very variable disease. And so this data cannot be extrapolated to the whole general population because in this study, the limitation of the study was they didn't describe their 24 patients with as much detail. So we don't know if those were infants with a milder phenotype or those who had less involvement or less organ involvement to begin with. So maybe they were a little bit more sturdy to begin with. So just to have that caveat in mind. Cardiac defects is also a big issue in these infants because about 90% of these infants have congenital heart disease as well. And this is, I'm going to now talk a little bit about more recent American data. And, since that study in Japan and, in the last 20 years, there's been so much advocacy, and now there is more and more research that's being published on what it can look like if we start treating these infants. Can we actually improve their morbidity? Can we actually improve their lifespan and the quality of that? So this was a study that was published in the journal Pediatrics in 2017, so relatively recently. And they looked at infants trisomy 13 and 18 who underwent cardiac surgery, which again wasn't even being offered 20 years back, but more recently is being offered. And what they saw was that in these infants with trisomy 13 and 18, heart surgery was performed in 7% of each group, so trisomy 13 and 18. And in-hospital mortality was decreased in those who underwent surgery, is what they saw. And it remained decreased throughout the 24 months of follow-up. So, the conclusion of this study was that heart surgery could actually decrease mortality. And for some families, that is valuable because for some families, their goal is to get these children home. And so potentially cardiac surgery could help with that goal. And this is another study that's often quoted by those who are advocating for these infants with trisomy 13 and 18. And this was also looking at infants with congenital heart disease and those who underwent surgery. And this is a Kaplan-Meier survival plot. Basically, what they showed was that of the infants who survived heart surgery, once they survive heart surgery, you could improve their survival as long as 16.2 years for infants with trisomy 18 and 14.8 years in trisomy 13, which is pretty dramatic, for what we have always known about these infants. And like I said, especially in the context of the fact that this surgery wasn't even being offered, and even when it was offered, it was a lot of concern about, are we really doing benefit to these infants? So, there has been more and more data recently showing that you could actually improve survival. But again, the other caveat to keep in mind is that doesn't mean that every patient with cardiac surgery could actually live longer post-surgery. What this study also showed was that, it is that identifying infants or stratifying infants into certain risk categories and identifying who are the infants that are of lowest risk and potentially getting them to undergo surgery could actually improve their outcomes. So it doesn't mean that it could improve outcomes in the whole population, but in a subset. And what some of the work that people are working towards now is to build that risk stratification and what are some risk factors that can improve survival versus not. And so these are some of the factors that we have identified, that we have some data to show that can actually improve survival. And those are female gender, infants that are bigger or higher birth weight to begin with, term gestation, infants who make it to full term instead of being born premature, absence of neonatal surgical anomalies, infants that are not requiring intubation or mechanical ventilation. And the reason I put a question mark in front of that is because there is some contradictory data surrounding that. So I think that still needs to be clarified. And infants that are overall medically stable. So it's important to recognize that the medical landscape is changing, but also to recognize that parents don't just rely on advice given by medical providers and the influence of social media that I think we're all familiar with in all aspects of life. And this is a quote directly from a patient I took care of. We are told that this condition is lethal, and then we find this online community with children alive. How do you not question the advice you are receiving? And this is in the context of the fact that as medical providers, we had been telling parents that this condition is lethal. And so that's what is creating this conflict. And so just to give give you guys context, there are so many support groups that are available online for families, and which is so wonderful. I think support groups are to provide support, so that is great. But the downside to these online support groups is that the loudest voices in these support groups are of the families who've had the most extraordinary outcomes. The ones that were told the baby won't live and the baby lives. Um, and so the problem with support groups is that sometimes they may end up homogenizing a heterogeneous disease. They can paint this disease which has many different colors in one single color. And so it can unfortunately misdirect families sometimes, because just because baby X was able to survive doesn't mean baby Y can survive, depending on the extent of how sick they are and how many of their organs are involved. And so that's the downside to support groups. And so as providers, we should be aware of what families have access to so we can guide them and work with them through it instead of alienating them. This is just a screenshot from one of those support groups online, which is the most famous, which is called SOFT. And they have tons and tons of resources for families with trisomy 13 and 18. And this is just a screenshot to show you guys that not only do they have resources, they have a list of places that offer surgeries for these infants, both cardiac and non-cardiac surgeries. So that's a very detailed website. And I think it's important for people, especially like us who are caring for these infants, to know what our families are accessing. So this is another comment from a parent, that how would you manage this problem if not for the diagnosis of trisomy 13 or 18? So what if my baby had this brain defect but didn't have trisomy 18? How would you manage that? And the response when a family asks us that shouldn't be to disregard the diagnosis, nor to defend ourselves, but to acknowledge the underlying themes that are being raised. There is a concern for ethical principle of justice. Families are saying that they feel like we are not being fair. To address the stigma associated with the diagnosis, and to express awareness of the difference in management and maybe some degree of mistrust that has already crept in through the relationship. This is also interesting. I have been in situations where a surgeon has told us is that this patient is not a surgical candidate. When a surgeon is making this judgment, they are balancing facts and values and include concepts that may be opaque to the rest of the medical team and the family. It may be that the proposed surgery is anatomically impossible. It may be that physiologically the operation will not make the patient better. It may be that the surgeon herself does not feel confident that she can bring the patient safely through the operation. The surgeon may feel that the goal of the operation itself is inappropriate or unachievable. Because the factors that influence this decision are not necessarily clear to all involved parties, such a decision can trigger concerns that the decision is motivated by judgments about quality of life rather than the chance of surgical success. And so that's what leads to the broken trust cycle. Parents internalize that their child has no value. They lose trust and they become, I hate to use these words, but we unfortunately hear them and we say them in medical settings, and they become difficult and demanding. And it's important for providers, for all of us who are caring for families, to understand that families that demand everything are generally families who are basically fighting to say that their child has value, and they want that validation from the medical team, which is a very fair.
I would just add, it's often at this point when the family has been labeled as difficult and demanding that the team invites the chaplain to come in to sort of support the family, but not really to support the family. They want to try to navigate the mistrust that is developing. So this is when we often enter at this point.
Yeah. Gosh, that's a hard
A hard
position.
spot. Yeah.
Yeah, yeah, it's hard. Um, and oh, sorry, slide. The other thing I think that just to, sorry, yeah, that the concept of, I think, again, this is all, I tend to give this talk generally to medical providers. So this is really important, I think, for all of us medical providers to be very, very aware of. But I think for all of you too, I think we're all a part of a team and important for all of us, I guess, to think about these. But I think as medical providers, we are guilty of falling into these traps. And so the concept of quality of life, I think, is itself controversial. It is often used as a synonym for objective measures of physical or cognitive impairment. And results from subjective approaches consistently show that people's self assessments of their own quality of life does not correlate with the objective measures of disability. And the disability paradox, individuals report a high quality of life despite impairments or chronic illnesses. Nevertheless, able bodied or cognitively intact individuals often tend to perceive the quality of life of the disabled as low. And I think that is a really big fallacy for many in the medical community. I think we really need to do better as far as this is concerned. And this is another study where, again, the quality of life was addressed, and both physicians and families were given a survey on quality of life. And what they found was that parents can generally accept levels of disability and still regard it as a high quality of life. However, physicians tend to interpret quality of life with regards to developmental outcomes, productivity, and contribution to society, whereas parents can view it more in the form of relationality and sibling connection, having meaning and giving meaning, and that many times has nothing to do with disability. This was a really important study because I have actually sat in family meetings as a trainee 10 years back, and I've heard my mentors say this to families that if you have an infant trisomy 13 and 18, your life is going to be terrible. It's going to hurt your marriage. It's going to hurt your siblings. So I think, we hadn't really looked at data. We hadn't actually gone and actually asked parents, what is it like for you to live with an infant with trisomy 13 and 18? And Annie Javier's group in Canada did this really important study. What I will say, the one caveat to the study was that it was based off of social media platforms. So, those are never representative of the general population. So just to have that caveat in mind. But they basically, like I said, they asked parents and families of infants with trisomy 13 and 18 of what was their experience like. And so parents of children who received comfort care and died described the overall experience of the child's life as being positive. 88% of those said that. 68% said they had no regrets, and 31% regretted that they did not consider more interventions. Parents of children who died despite interventions, so they offered to put them through interventions and they died after that, described the overall experience of their child's life as being positive 89% of times, with 89% reflecting that they made the right decisions with no regret. Parents reported being told that their child was incompatible with life 87% of times, that they would live a life of suffering 57% of times, that their child would be a vegetable 50% of times, or would ruin their marriage or family about a quarter of times. However, parents reported that some providers did tell them that their child may enrich their family, they might have a short but meaningful life, or might survive many years. 82% of families felt that this child had a positive effect on siblings. Of all the parents, 3% reported that their marriage dissolved since the diagnosis of trisomy 13 and 18, so a lot lesser than we had expected it to be. And 68% stated that this child had a positive effect on their relationship. 44% of those whose child lived longer than 1 year stated that they found the financial sacrifices related to their child to be very challenging, and about half stated that their child experienced more pain than other children. Half of the parents reported that taking care of a disabled child was harder than they expected. Despite most parents describing their children as having significant neurodevelopmental disabilities, 97% of parents described their child as a happy child, and stated that they were able to communicate with them to understand their needs. Most parents reported that their family was strengthened since the birth and often the death of a child with trisomy 13 or 18. The same group looked at pregnancy, at prenatal diagnosis of trisomy 13 and 18, mothers who were given the prenatal diagnosis and what was their experience like. And the parental hopes, that the themes that came up were wanting to meet their child, wanting to bring their child home and be a family, and for their child to have a good life. And the parental wishes and fears were to be able to give their baby a chance, to know that they did the best they could for their child. And the biggest fears that came up in this study were pain, medical complexity, and life in the hospital. And this had similar results. So I would just want to, if I just look at for respondents whose child died, 91% said that they thought their overall experience was positive. And of those whose child lived, also 91% said that their child was a happy child, and that 97% felt that their child enriched their family life. The other thing I thought that really stood out to me was that about a quarter of these infants who lived longer than 3 months, they felt that their child experienced more pain and discomfort than other children. So that is a considerable, thing to keep in mind. And that caring for their child is more difficult than they thought it would be. About 1/3 felt that way. And about close to half felt that their family experienced significant financial challenges. This is just to give, just to give context. This is the pictures. These are pictures when I was in med school. These were the pictures that were in my textbooks, and these are common pictures that are in articles as well of infants with trisomy 13 and 18. And the paper that I just spoke about, they published these pictures of infants with trisomy 13 and 18, and just again to give, just to note the difference of the usage of color, the faces that have smiles, the faces that are looking at other loved ones, and just again, all of this is really to speak to our biases. There is data in terms of how these children do, but then there's also the way we treat them. There's also the way we perceive them and their life to be. And I think this picture is just to denote that yes, their lives are very challenging and very complex, and many don't live, and many have short and complex lives, but despite that, they can smile, they can have meaning, and they can have relationships that could be meaningful. And so what they concluded in that study was that parents should be informed that most parents who choose to continue pregnancy have reported a positive and enriching experience, regardless of the lifespan of their child. Most parents who choose to continue pregnancy do so because it is the better path, according to their personal beliefs. And they appreciate empathy and kindness on their extraordinarily difficult journey, especially recognition of and respect for their love for their child. And this is always the most gratifying thing to do personally when I am doing these consults prenatally and when I see them after birth, is what I find the most moving, and what I think really helps build a relationship with the families is to acknowledge this, is to acknowledge how excruciating it is to make these very difficult choices and how deep their love is, because every parent is coming from a place of love when they make decisions on how they decide to love their child. In terms of neurodevelopmental impairment, majority of these infants are non-ambulatory, but some older children are able to crawl, sit, or ambulate. In most cases, expressive language is not achieved. However, they can smile and laugh, roll, sit up, understand words and phrases, use a few words or signs, and follow simple commands. These infants have significant delays and many skills. However, many skills can be achieved eventually if they live long enough, such as sleeping independently, self-feeding, recognizing family, etc. These children will be dependent on their families for total care for the rest of their lives. So it is a very significant undertaking. And this is just, I find this personally very helpful. I look at this every time I'm changing the way I counsel these families, and very important to be aware of how we word this diagnosis and how we talk to these families so we can build trust and actually be on the same team as we care for these infants. So to not say, and I used to say these things, and I feel I now struggle with the fact that I used to, but we used to say things like this is incompatible with life, and this is a lethal diagnosis. But what we are now encouraged to say is things like this diagnosis and this infants with these diagnoses may enrich the lives of these families, and they may have a short but meaningful life, that some survive for days, months, and years, to make sure we ask the parents for their unborn child's name and to respect them that way, to offer to take pictures, to ourselves refer them to good resources, so that there we can collaborate, and to describe all organs, describe those that have malformations, but also those that don't have malformations. I think we went over most of these things, so we can move on. So I think, moving towards the end, what is the ethically right thing to do? Like I said earlier, good ethics begin with good facts, but facts can be muddled by self-fulfilling prophecies. And some reflections is the quality of life experienced by people with severe disabilities so unacceptable that it is unethical to prolong such lives? Are we allocating expensive healthcare resources to patients who are thought likely to die? Is it disconcerting for us as providers to be in the gray zone, where some parents choose comfort care while some want all available life-sustaining technology? So some guiding principles towards the end: to listen and not assume. I think you guys are really good at doing this. I think as medical providers, I think physicians need to get better at it. To practice a non-binary approach, to avoid never and always, to watch our own biases. Data can reflect values for patients in the gray zone, and to recognize that this is truly a gray zone. Just to give again more context, I have taken, I do these prenatal counseling all the time, and I take care of many parents who offer to provide comfort care after birth and don't want to put their child through interventions. And there are many who choose to. And they are both appropriate, loving ways to care for their children, and to be careful that I don't let my own biases into that room as we're making those decisions. To provide balanced counseling and to hone our skills of moral neutrality and tolerance. To involve all caregivers, especially nurses, in family meetings. To empower parents and offer reasonable hope. To express humility in this gray zone that we as providers don't always know everything. To encourage shared decision making, to ask parents who would they like to make decisions with a pastor, with you guys, with elders in their community. To encourage strong communication between specialists and approach these patients in a multidisciplinary fashion. Thoughtful and evidence-based selection of surgical candidates. To individualize care based on comorbidities and parental values and goals. And to engage with a broader community of pediatric specialists, so we can avoid silos of trisomy-friendly hospitals, and we can all provide equitable care. And I think that brings me to the end. This is a sweet baby with trisomy 18 that I had the honor of taking care of. Parents have given me permission and are actually very happy when I share her pictures in conferences, because they are overjoyed with with what they have, this little beautiful girl has brought to their life. This mom was a very strong advocate, and she was our first patient at the Children's Hospital of Oakland to get cardiac surgery. And she was repaired and she did well. And as you can see, she is at home, celebrated Christmas, and needs a lot of medical care. As you can see, she is still on oxygen. She has a feeding tube in her stomach. But according for her family, that is a meaningful life. And I'm very glad we could support them in that. And I will stop sharing.
Thank you so much. I'm so glad you were able to come today. And I would love to share with the team, especially that slide on what to say and what not to say. Because often in those family meetings, I do hear physicians saying some of those not to say things. And I've always longed for alternative language other than so often what I do is just acknowledge, wow, that was hurtful. Is there another way you could phrase it? And sometimes the physician's at a loss. So it would be helpful to say, maybe we could phrase that this way. So I would appreciate that slide to share with not only this team, but my team of chaplains. There's 10 of us at Alta Bay Summit Medical Center.
Yeah.
And then this is a shameless plug to take an opportunity to encourage you to invite the chaplain, even if the family says that they don't have any religious traditions. Chaplains are also available for emotional support in ways that other members of the care team simply cannot. They don't have the bandwidth, they don't have the time, and that's not their particular skill set. So that even that term chaplain can be a turn off. So it could be spiritual care member that could come to the family meeting. There's so much we can offer because we get to linger and we get to stay with them when the meeting's over and the team is gone. So I advocate you inviting us into those meetings, and any questions, feedback, comments from anyone else. Thank you so much. I'm so glad you were able to come. This is so
Thank you.
helpful for us. Yes.
Thank you for everything you said, and thank you for doing the work you guys do, because I really think, like I said earlier, these are extraordinarily hard times for families, and they need all the support they can get, and they need understanding and compassion and thoughtful language. And I appreciate everything you guys bring to the table, and I appreciate the reminder to engage with you guys more. And I think this is really a teamwork. This is really we need multiple layers of support and dialogue with families when they're going through these hard times. So
Yes. One of the things to just encourage your confidence in inviting us to the conversation, you might not ask the parents, should I invite a cardiologist? You would, out of your expertise, invite a cardiologist or whomever you needed their expert skills of that provider. It's kind of the same way with us. I encourage, don't ask the parents if they want the chaplain. Understand that we have a set of expertise and skills that they need. Yeah, and we, it's just a different understanding. Because often if you say, do you want a chaplain in this difficult situation, the family says no. Not knowing the skills and expertise that we can bring to the conversation. So feel empowered to invite us. We know what it is to be kicked out of rooms. We don't have a problem with that. And we also know how to communicate what we can provide in terms of emotional support and advocacy. And that's often the turning point. They're already feeling some mistrust. And then here someone comes from the care team who can be an advocate and really can diffuse the mistrust. So be empowered to just add this without permission.
No, I appreciate that. I do think there is such value in having a third person outside of the day-to-day care team come in afterwards and, provide support, help bridge gaps, solicit feedback, sort of help be the liaison, so to say, even. So yeah, I do appreciate
Yes.
that reminder.
Yes. Alice, Marcella, Lisa,
Oh,
any questions or
um,
comments you'd like?
I am Marcelo. Nice to meet you. My camera is not work. So thank you very much for this information. There are several aspects that I don't know. This is a very interesting area in the my life, in the a lot of family lives. Thank you so much. I appreciate.
Thank you.
Thank you really so much. I have known before of trisomy, trisomy 18 and 21, but not much of an elaborate explanation of 18 and 13, which is very helpful. I have a daughter with disability who have chromosomal deletion too. And this is, it's really, really helpful because I know that when I was adopting my daughter, she was 1.5 in foster care. Everybody told me, oh, she's not going to leave. She's not going to, the discouragement was so high. What is the point? She won't have any quality of life. My daughter is 11 years old, thriving little girl. She has still multi-layered levels of disability, but she's thriving. She's the most happy. Yes, she might not be the daughter that everybody expects with cognitive abilities to do things in school, but she she's a person of her own. Her dignity and worth in her vulnerability is profound. And I hear you talk a lot, and I really connect it. It's in the dignity in vulnerability, that person is fundamentally human. And that person's value is not dictated by the brokenness of their body, but is determined by the deep value as a person. And so I really appreciate the work you're doing in that domain. And as a medical doctor, I really am surprised because medical doctors are very obsessed with cure. And they see cure as is that which the essence of their job is to cure this person, prolong life as possible. That is their job. But I hear you when you talk about comfort care as a value in it to accompany people who want prolonged care. But also who choose to go comfort care, especially in 18 and 13, which are the most the two that is the life expectancy is very short. So I love to see that. It warms my heart to see someone who is a medical doctor in their profession, which is their profession is to cure, but who deeply values life beyond just cure, but life that sees the value of life beyond a body that is entrusted in my hand to fix. And the fixing is not just your goal, is making sure that that person's dignity is recognized and accepted, and the goal and the central goal becomes that. So I was listening to you and my heart is so really warmed because right, my experiences are not those. See, I take my daughter to the hospital. They're just finding in her body what part they can fix, And hardly have I even had any of her medical team. She has so many people in her medical team because of her problems. Somebody just asking me question about the quality of life. Somebody just focusing on her value, So to hear that is a kind of work you do for me is huge. And as someone who is called also into chaplaincy, where for us, fundamentally, we walk through the lens of the theology of presence, right? That is, and to be there, and that our job also is to emphasize the value of dignity of every human being. I just want to appreciate you for that. So thank you.
Wow, thank you. My gosh, I have chills. Thank you. It's very, very kind and thoughtful, and I so appreciate you sharing your own experiences with your own daughter and what it is like and how sort of affirming my passion. I really care deeply about this, and I knew this is going to be a receptive audience, but that I have had to give this talk in some audiences that I knew it would not, go down so well. But I think it's very important to bring this message across the board, and especially for medical providers to reflect on many of the things that um, I think people tend to overlook. And I think I also feel like I have such respect for what you guys do too, because I also think you guys do work of the heart and less of the ego. And I think medical providers are oftentimes led by their egos. So I think it's important to remind people, remind folks of why we do what we do. I think most medical providers chose to go, I like to believe most people chose to become doctors to help. But I think somewhere during the path, we lose sight of that and tend to get driven by our ambition and our yeah. So I that's also why I think this is very important. Is I think to me this work grounds us in what truly matters. So thank you for seeing that and supporting that.
Lisa, I see you have unmuted. I didn't know if you wanted to make a comment or not. Are you good?
No, I just want to thank you for the share. It was good. I did have one question of Downs is not considered a person. What is
Hmm.
that still? Is that still something that is considered, or
Oh my
that
God.
was just in the 60s?
Yes, that quote was just to give context on how things were in the 60s, and thank the Lord that is not the case now. We
Okay.
are far from that. We are far from that. Children with Down syndrome are treated no different from a child with uh, the regular number of chromosomes, which is 46XX, but we don't treat them any differently. They are given full care with full respect and dignity. There's no limitation. There is no um, yeah, no one will ever say that again. It's atrocious to even read it for me today. I
Mhm.
struggle with even saying it out aloud, but yes.
Yeah.
And I'm
Thank,
so glad it's not that way.
thank you.
I appreciate you prefacing and the times I've heard you do this presentation, you always preface how difficult it is for you to even read that slide. And even though I know it's coming, I'm still
I know.
unsettling. Yeah.
Oh my God.
To hear it. Because the 60s are not that far
Right.
removed from
68,
us.
right?
Yeah. Yeah.
Yeah.
So
I mean, just the fact that they could say that it's a certain life with whatever diagnosis is not a person.
yeah.
It's just it hurts my soul.
Yes.
But
And
also why it makes it more, even more important to talk about this now, because we
I
must
agree.
change and we
Yes.
do better.
Thank you so much. I am so appreciative of you coming. I'm appreciative of your work. Your presentation is powerful and your passion comes across. And on behalf of not only the chaplains that are here, but all of the chaplains at Altabay Summit Medical Center, consider us your allies. We're here for you.
Thank you.
However, we can support you in the work you do. Thank you. Thank you
Thank you.
so
Thank
much.
you for listening with such attention and care. I so appreciate open hearts and hearts that want to care. So thank you
Yes.
for everything you guys do, and I hope we can keep doing the good work.
Yes. Yes. Thank you.
Thank you.
Have an awesome day.
You too. Thank you.
All right. What a gift. We were texting back and forth and I didn't think she was gonna make it. So I didn't even mention it again. I was like, they don't remember she was coming. So I won't mention it. And then she was like, I'm here. I'm like, oh, I'm coming. So she's awesome. And
Yes,
I can tell you can
Yeah,
appreciate that. And
very good.
so refreshing to work with her as a chaplain. And I hope she calls us more. But yeah.
Do
But
you have a PowerPoint?
I will send her an email saying, hey, we really need your PowerPoint. That
Okay,
what to
thank you.
say and not to say slide is so helpful. But I will reach out
Exactly,
to her
thank
when
you.
I send a thank you note and ask for the slides. And if she can't share all of it, because this is a presentation she frequently does, she'll at least be able to share that slide. Is there any other particular slide you want to make sure she includes if she says she can't share it all?
No, she can share just what she feels like sharing, and
Just whatever.
anything she share will be
Okay.
helpful.
Okay. Great. That is good. Okay, we do need a break. Sorry, Alice. But I thank you all for your flexibility. I don't mean to be so excited, but getting Dr. Mandini was no small feat to get on her calendar. And as you know, we have no budget. So for her to take the time to come, I was so happy. So let's take our because I'm going to get up and do a dance. Let's do our self-care education and practice session. And I will see you back here at 12:30 and for Lisa 3:30. And sure enough, Alice is going to kick off our verbatim. All right. I will see you then. Thank you. And thank you for your, each of you expressing appreciation to her. Thank you.
thank you. See you 12:30.
All right. 12:30.
Yo, hijo, ¿ya pasaste? Oh, ¿hasta qué hora sales? ¿Hasta las 3? Yo aquí me vine al Starbucks porque nos dieron un break. Me compré algo porque tenía hambre. Y ya, pero aquí estoy pegado al aeropuerto esperando. O sea, el hermano es como una hora. Ya ahorita, en 10 minutos entramos, en 5 minutos entro a clase y ya, nos dan otro break y le voy a avanzar. Eh, Dale pues, hijo. Ahí estamos. Bye.
All right, we are all back. Thank you for coming back in such a timely manner. I'm going to flip the script just a little bit, and I'm going to ask the chaplain to read in the verbatim the words of the care receiver, and then for others to volunteer for everything else, including the parentheses. So we're just going to flip it a little bit. The chaplain, when we get to that, is going to read what the care receiver shared. So, and then the rest of us will cover the rest of it. All right, take us away, Alice. I have a copy of it, so when I'm looking away, I'm looking at my written copy.
Okay. So the date for this visit was 4/3. Verbatim number 4, and the care receivers is Lizzie. I've done a verbatim for her before, so some of you might recognize. She's 57 years old, heterosexual female. Husband name is Nick Casper. Diagnosis: undiagnosed chronic illness. Black African American African. That term is Christian. At her home. Length of visit was 1 hour, and this was visit number 5 with her. So this was my 5th meeting with Lizzie, but it was by far the most emotionally intense and spiritually significant. I bring this visit because I want to reflect on how to be a companion to someone in a long season of suffering without offering cliche or rushing them to hope. I want to explore how to create space for honest lament without spiritualizing pain away. I'm seeking guidance on navigating my discomfort with sitting in unresolved suffering. I want to reflect on how to ask open-ended questions that draws out someone's deep experience of God in their suffering. So the outcome indicator 1-5, I think I accomplished it in this. I value presence over answer in spiritual care. This visit was about honoring Lizzie's grief, not trying to fix it. 1-8 demonstrates Lizzie's pain shaped her view of God as distant. I honored that without judgment and allowed her space to name her feeling honestly. 1-9, I listened deeply, reflected her emotions, and asked questions that allowed her to share openly. 1-15, rather than collecting facts, I explored her emotional and spiritual experiences and how illness has shaped her relationship with God. 1-21, I discussed my first pastoral visit care with Lizzie in supervision to process emotional weight and receive feedback on holding space for lament. That supervision meeting and our conversation have remained a strong foundation for subsequent meeting with her. Background: Lizzie invited me to her home because she was struggling with faith. It's 5 years of undiagnosed chronic illness. Her condition has left her unable to walk, barely able to walk, ORK, barely able to walk, ALK, and struggling with speech. She shared upfront that she was in a crisis of faith and felt forgotten by God, which was how she called me. And normally our meetings are Fridays evening, but she called me on Thursday and like, I really want to talk. I'm feeling low. And will you be able to come? Thankfully, I was able. So the meeting shifted from Friday to Thursday. Personal status. I felt a deep sense of tenderness and responsibility as I prepared to visit Lizzie's for our FIC meeting. I knew this visit was different because she had specifically asked to see me, naming her ongoing spiritual struggle. I carried with me both compassion and certain heaviness, aware that I was stepping onto sacred ground, a space of raw honesty, deep pain, and fragile faith. I reminded myself to show up with gentleness, patience, and humility, knowing that no words could fix what she was going through. My heart was focused on simply being present, creating space for her voice, story, and lament without rushing towards hope or resolution. The pastoral purpose of the visit to offer a compassionate, non-judgmental presence, give her permission to lament and be honest about her pain, to explore scripture and prayer as possible source of comfort if she desired. Goal, to listen deeply without rushing towards hope, create space for spiritual wrestling, remind her that her question and struggle are seen and valid. So the dialogue.
I can be, did you want her to be, you want her to be the care recipient, right?
So L.
So I can be the chaplain, huh?
Yes.
I'll be the chaplain and
Chaplain.
you be the care. Okay.
Okay.
Do you
So
have
who does the,
parentheses?
sorry?
So, Marcelo, do you have good audio now or no? You do?
I think so.
I think
Yes.
so too. Would you read what's in parentheses?
Yes.
Okay.
Okay. C is chaplain. L is me, right?
N-
The parentheses. Lisa will be the chaplain, and you're going to read what's written in parentheses. So you start us off, soft smile. Uh-oh. Are you frozen? I think he is.
How do you want to move forward?
Okay, there he goes. Yeah, we're not hearing you, but I hope you can hear us clearly. Yeah. Okay, good.
So what part do you want me to do? You want me to do just,
uh,
I mean, I know what part I'm supposed to do, but since he can't do his, am I doing that or?
yes, go ahead, do
So,
both.
so
Oh, there he is. Okay.
Okay. Lissy, it's good to see you again. Thank you for trusting me to come.
we are tired. Sing.
Thank you for coming, Dr. Alice. I've been waiting for this visit, like someone waiting for medicine.
Feeling humbled and heavy inside.
That means a lot to me. How have you been feeling in your heart these days?
Pause. Eyes willing up.
To be honest, empty, forgotten. I pray, I cry, I fasted, I believed, but nothing has changed. My body is weak, my soul is weaker.
Listening deeply. Hurts. Aching.
That sounds incredibly lonely, Lissy, to keep reaching for God and feel like there's only silence.
Exactly. Where is this God I have trusted all my life?
Voice breaks.
I'm tired of believing for nothing.
Pause to breathe with her pain.
What has, no.
What has been the hardest part for you today? I mean, for you lately?
Waking up and realizing this is still my life. This sickness is still here. No answers, no healing, no word from God.
Softly,
That sounds like Psalms 13. Would you mind if I read some of it?
not slowly, tears failing.
Please.
I open my Bible and read Psalms 13 aloud slowly and gently.
How long, O Lord, will you forget me forever? How long will you hide your face from me?
Whispers,
That's me. That's exactly how I feel.
feeling, feeling goosebumps from the road through.
Yes, this is the honest cry of someone who loved God but felt abandoned.
Pause,
What part speaks to your heart the most?
thinking,
How long? Because that's all I keep asking.
softly,
It's a holy question, Lissy. God is big enough to hear how your how longs.
tears continued.
You think God still sees me?
Hearts full of compassion.
I believe yes. Even your tears are prayers, Lissy. Even your anger is prayer. You are seen.
Quiet.
I want to believe that.
Can I pray with you? Not to fix anything, just to sit together with God in this moment.
Yes, please.
With her hands and her request, I prayed slowly, affirming God's presence, asking for the comfort and strength. No promise, just presence. You're
Thank you, Mr. Marcelo.
welcome.
Analyzing the person's situation. Lizzie is deeply struggling with spiritual isolation, chronic suffering, and emotional exhaustion. Her crisis of faith is real and raw. She longs to feel seen by God, but is weighed down by silence and unrelenting illness. Reflection on my emotions during the visit. Sitting with Lizzie in her deep spiritual emotional pain stirs so much within me. I felt an overwhelming sorrow, not just for her physical suffering, but for the loneliness, disappointment, and spiritual exhaustion that she carried so heavily. There was part of me that desperately wished I could offer words that would fix her burden, would lift her burden, or some promises that things would soon get better. But I knew that doing so would have been more about easing my own discomfort than honoring her reality. I found myself wrestling internally with that natural urge we have as caregiver to fix, to comfort quickly, to wrap pain in easy hope. But as I listened to her share her honest cries of feeling forgotten by God, I felt deeply convicted that this was sacred ground, not fixing ground. My role was not to change her story, but to hold it with tenderness and reverence. I realized how easy it would have been to spiritualize her pain or rush past her question with Bible verses that didn't meet her where she was. Instead, I had to stay rooted in compassion and patience, trusting that my presence, listening, and non-anxious companionship were enough in that moment. I felt the visit humbled and reminded that pastoral care often means sitting in the mystery of suffering without clear answers and trusting that God is present even in silence. Effective response. I intentionally created a safe space and compassionate space for Lizzie to express her deep spiritual pain without fear of judgment. I listened attentively, allowing her to name her anger, doubt, and sense of abandonment by God. I asked open-ended questions like, what has been the hardest part for you lately? And what part speaks to your heart the most? These questions allow her to speak honestly about her struggle without my rushing to offer answers or theological explanation. When she felt forgotten by God, I validated her pain and gently reflected back what I was hearing, that she longed to know God still saw her. I also offered Psalm 13 when she invited me to pray, which felt deeply meaningful and honoring of where she was spiritually. Areas of improvement. Looking back, I realized I could have explored more about how Lizzie had coped spiritually over these 5 years long. I wonder if asking questions like, have there been moments where you felt even a glimpse of comfort or God's nearness might have opened space for her to reflect on moments of resilience amidst her suffering? I also noticed that I defaulted to reading scripture and praying for her rather than asking if she would like to read or pray aloud herself. In future encounters, I want to be more mindful of empowering care receiver to participate in their own spiritual care, even if their physical capacity is limited. Like her, she slows a lot, so I should do that. Personal and professional growth. This visit with Lizzie reminded me once again that spiritual care is not about providing solution, but about showing up and staying present in life's raw, unfixable spaces. It stretched me to resist the urge to comfort her quickly or explain away her pain with easy theology. Instead, it deepened my awareness of how vital patience, empathy, and non-anxious presence are in spiritual care, especially with those wrestling with long-term suffering. This visit also helped me grow in emotional self-awareness. I noticed how much I wanted to rescue her from her pain, but I knew that would have been about easing my own discomfort, not hers. Moving forward, I want to continue practicing the kind of chaplaincy that listens more than speaks, wait more than rush, and honor lament as a holy and necessary part of faith. Spiritual assessment. Lizzie's primary spiritual struggle centers on feeling forgotten, abandoned by God due to her long undiagnosed illness and loss of physical independence. She wrestled with profound question of God's presence, love, and care amidst her suffering. Her need is not for answer, but for presence. Someone to bear witness to her pain and to affirm that even in her doubt and struggle, she is seen and loved. Spiritual care model I use a presence-centered model of spiritual care, focusing on deep listening and open-ended questions. I allowed Lizzie to articulate her feeling of abandonment, grief, and longing for God without rushing to resolve her struggle. I also use elements of meaning-making approach by inviting her to reflect on where she has seen glimpses of God. On nearness, no, I did not. I wanted to say I did not do that. That is what I hope to do in the next journey. Even those moments are small or fleeting. Key pastoral intervention use empathy, listening. I stayed fully present with Lizzie, reflecting our feelings of abandonment and isolation without minimizing them. Validation of lament. I affirm that it is okay to question, doubt, and grieve deeply. That lament itself is a form of faith. Use of scripture. I read Psalm 13 at her request, allowing the psalmist's word of anguish and hope to speak into her own pain. Offering prayer, I prayed gently with her, focusing on God's present comfort and faithful love without promising quick fixes. Theological and philosophical reflection. This visit with Lizzie brought me face to face with one of the hardest and most secret aspects of chaplaincy, sitting with a person in the wilderness of unanswered prayers. It reminded me of the Psalms of Lament, especially Psalm 13, where the psalmist cried out, "How long, O Lord, will you forget me forever?" This story embodied that cry in such a raw and honest way. Spiritually, this encounter deepened my conviction that God meets us in our vulnerability, and that lament is not the absence of faith, but an expression of it. I was reminded that Jesus himself entered into people's suffering, often with silence, presence, and compassion, more than with answers. Philosophically, this visit affirmed that spiritual care requires courage, the courage to sit in mystery, be fully present in suffering, and trust that God's grace is at work, even when we cannot see it. This visit reminded me that spiritual care is sacred, not because we fix pain, but because we dare to stay near, bearing weakness, holding space, and loving people exactly where they are. Ethical and social justice issues. The lack of medical diagnosis for Lizzie's condition raises issues of healthcare inequalities for women, especially Black African immigrant women who often experience medical gaslighting or dismissal. The isolation of long-term illness can increase vulnerability to depression, anxiety, and spiritual despair, which is exactly where Lizzie is at currently. My role was to honor her experience without minimizing it and to affirm her work in a system that often makes people like her invisible. Future plan to check in with Lizzie in a week. Actually, it's in a week. I see her every week in a week.
You see her every week at her request, or that is
Yeah, she has explicitly requested from day one
okay.
if we could talk. The only week we didn't really talk. There are some weeks we didn't talk because she had a doctor's visit, and the week she wanted to talk the week with patients funeral. I could not, and I'm sorry I didn't. I think that's why she called me the next week. I really want to see you. But anyway, when I can, I try to see her every week.
Okay.
I want to explore whether there are small spiritual practices that bring her even a little comfort. I will be mindful to hold space for her lament without rushing her towards hope. I plan to consult with my supervisor for guidance in working alongside long-term suffering. That's it. The next is just chatting, which gives the same thing. Met with Lizzie for spiritual care amidst illness and crisis of faith. Care recipient expressed feeling of abandonment by God, frustration, grief, and isolation. Provided deep listening, spiritual validation, use of scripture and prayer, follow-up visit plan for next week.
Very good.
Should I stop sharing?
Yes, you may.
Let me move this view. Why does it say gallery?
It's clear on our side.
You can hear me?
Yes.
Yes,
Oh.
Marcelo.
Okay, Lisa, thank you. The learning goals reflect desire to accom accompany through listening, humanity, and respect uh for the name the Lizzie for
Mhm.
the Lizzie. So the situation is delicate as Lizzie requires deep compassion, empathy, and sensibility. Um, so I have a question. Um, what follow is a possible way to respond?
That question's for you, Alice.
Or Donna. Yeah.
Can I push it to the supervisor?
I'm gonna put.
Okay.
I
Yeah.
agree, Marcelo. It does require all that you described. And I think some of the ways that Alice did that so powerfully was to not rush the space, to um, try to create space for the lament, um, to use not just open-ended questions, and I'm happy to talk about more, but to use sort of what we call these superlative questions. What was the hardest? What was the um, I have a curiosity. So I think that I hope that addresses your question, Marcelo.
Yeah, I sent to the question for the chat.
Okay, thank
What
you.
possible way to respond in this special situation?
Yes, and I think the ways you responded, Alice, are excellent ways. And here's one curiosity that might get at one of your requests is you said one of your goals was to create space for spiritual wrestling.
You
Why?
know,
Why would you want to create space for spiritual wrestling?
Because that was exactly when I just felt it was a crisis of faith. And again, crisis of faith in the phone call, again, obviously, the dialogues cannot always capture everything. In the phone call, one of the things which really made me to go on that Thursday, even though I had to cancel something else, meeting with students to go, was she was really in the verge of, oh, because I think she shared the husband, she's also very depressed. The husband was like, you are questioning God, don't you know it's a sin to question God? So in that space, when I felt that deep sense of crisis of faith. My immediately thing was, okay, this is something I have to go that Thursday. But not also that, I really wanted to create space for her to know, to validate those crisis moments, and to also make her understand, to be in this space of questioning, is okay, is good. And I just wanted her to just know that it's okay to wrestle, to that is okay. It's empowering to actually wrestle. And because for me, that's also is a sign of faith. So I didn't want to be like the chaplain where she sees a chaplain and they know me not also as a chaplain, as a minister in the church, that she doesn't feel like I was there to validate what the Casper was told her in terms of you don't question God, God's will is the best, right? That kind of, I didn't want her to feel that. I wanted her to know, just like Jacob, you can wrestle
Okay.
with God.
So
And yeah,
you assessed there was a spiritual crisis, and part of that spiritual crisis was questioning God. You assessed that you needed to have the spiritual care intervention of advocacy, advocating for questioning God is okay, doesn't mean a lack of faith, and advocating for the wrestling. So I asked you why, because I'm affirming that as a part of your assessment. And then the next question becomes, well, how did you do that? How do you invite someone to wrestle with God? And the how in here, you advocated that it was okay and you gave space by being present. Is there any other way that you invited her to spiritually wrestle?
Yes, and I think that when I told her that really sounds like Psalm 13, it was a way to say there are precedents. You know, that see, the Bible canonizes that kind of lament. So so I was also inviting her. Actually, she called me last night to tell me she reached Psalm 13 now. It is a form of prayer for her.
Very
And
good.
she sees herself. So that was a way that I when I brought in, so this, it really, you really, that really sounds like Psalm 13 was a way to how to do it. And that's what she does now. She said for the few days since we met, she's been praying Psalm 13 and owning it.
So you assess the need for to be able to wrestle with spiritual crisis. You advocated for that, particularly given she had been discouraged. You showed her in her book of her sacred text, scripture, where there was, as you said, precedent that had been done before. Then you invited her to a degree doing it in this space. And so that all of those interventions correspond with what you assess. And I think, Marcelo, are excellent ways to respond in this sort of situation. How were you a non-anxious presence? When I read what you've written, I'm very much aware of how anxious you were. How were you a non-anxious presence? And let me frame it this way. I'm going to ask you how you were a non-anxious presence. And I want to know your thoughts about whether or not a non-anxious presence is appropriate for spiritual wrestling.
How was I not? And if I say I was 100% non-anxious, that's a lie. I wasn't 100% non-anxious, but I tried to make it her moment. I tried to, again, I was using a lot of validating phrases. So I tried to stay present in her moment, because if I did not, I would not be able to create that space for her to rest. So if I was an anxious presence, as I know myself, who I am when I'm really anxious or affected by the recipient situation, I think I would say I did the best I could to stay present, to create her the space that she needed, and to let her feel I was really 100% there with her.
Excellent.
I think that's the best way I did it.
I think that's powerful. And I think from what you were able to share with us, I think that comes across. I'm curious about that expert use of Psalm 13. When you heard her share her wrestling, and you said, that sounds like Psalm 13. Would you mind if I read some of that? I'm curious about what it might be to express how that felt before shifting to the sacred text.
I think that's what I said was one of my learning, the learning
I mean,
urge.
felt for you. I mean,
Okay.
to say, to be a little bit vulnerable in how that what you're hearing, what you're feeling before you
Right.
shift to the text, which is kind of sterile, and you're going to the psalmist. Yeah, you say how you feel. Not me. I'm not gonna say how I feel. But you have so non-anxious doesn't mean non-vulnerable.
Right.
So you still get to be vulnerable with whatever felt authentic without taking it over and making it about you. But now she has this, if you will, dead witness in the psalmist of wrestling. And she also has the potential in you to have a living witness of wrestling. without taking it over. I too wrestle with God. Sometimes I get so frustrated or whatever. You follow? So that's just
Yes.
another way of going to
Mhm.
another layer. 5 visits in, you can do that kind of thing where you
Mhm.
actually invite even more the wrestling. Very, I think this was very good.
Mhm.
Yeah.
Mhm.
Lisa?
Thank you.
That's kind of confusing when you say she can say something and it's not really like taking over the conversation. It's kind of confusing because where's the limits there, you know? Um,
If
because
I
I don't know.
if I'm present and I'm struggling to hear what someone's saying, right? And I'm present, I can continue to be a non-anxious person and say, wow, this is really hard to hear. I feel this in my heart. This is difficult. This is whatever, without
Mm,
making it all about me. So in her example, the psalmist is to use that language again, if you will, is dead, ancient, disconnected culturally, although impactful and powerful, and I thought expertly used.
mhm,
Another witness is Alice, who's alive, who can also bear witness of I too struggle with what feels like the silence of God. It's so hard. And then you keep going. You don't make it about you, but you get to be vulnerable enough to just acknowledge it too. Does that make sense? Is that a little bit
mhm.
clearer? Without taking over, because you're absolutely right. You don't want to take it over and make it all about you. So that's why I said, is non-anxious presence the only presence you want to be? You might also want to be an embodied witnessing presence to this sucks. How
Mm.
many times I have said to the person who's had their last chemo and it's not working, and I say, this sucks, right? But I've got some rapport, and they go, yeah. And we continue.
That's true. That's true.
Mhm.
That's just another level of permission and invitation.
Mhm.
Good.
Mhm. Mhm.
I thought it was a well written verbatim. I like the questions that you asked. What has been the hardest part for you lately, and what part speaks to your heart the most? I struggle with trying to ask those type of questions because they seem kind of invasive and they seem painful. I'm not saying that you didn't do right because it is, but I struggle with it myself to ask a care recipient or receiver those questions. But I thought you did a good job at it. And even when you answered her when she said something, I can't remember. And also you know because you didn't write your your responses when it is it's even your tears
Mm.
are prayers and your anger is as well. I thought that very powerful, you know.
Yeah.
And wow, I mean it you know, you that was excellent to me. Um
Thank you.
and you demonstrated awareness with her oriented system. So I think that you did very well with that. Um but you never talk about the language of countertransference.
Mhm.
Um, it's in there, but you never say the language.
Mhm.
Can you give her an
Yeah.
But
example
otherwise,
here?
um, it's not. I should have wrote it down, but it was something she was saying that how it affected her. You know, I can't remember what part it was. It was at the end, but she was saying how that it affected. You know how she felt about it. I can't remember it now, but I felt like it was a little bit countertransference going on. But I don't have it before me. Um,
Yeah.
I can't, I'm sorry, I should have I wrote most of it down, but I didn't write that part down.
Yeah. Towards the reflective moments of the towards the end when I'm reflecting on the whole thing. And yeah, the language of
Right.
it is inferred. It is inferred even if not explicit. Because again, the truth is I've prayed, how many times have I prayed Psalm 13? right? So I know what it
Mhm.
feels, but at the same time, you're present. You are. So when that kind of, when she cried to me on Thursday on the phone, this crisis of faith, I know because I've gone through that too, So there's some level of Psalm 13 is my favorite in moments like that. So it's not like a psalm that just came to me. It's a psalm, So there's that kind of elements, Yeah, we even though not explicitly highlighted, it is somewhere in the background.
That's powerful. Good self-awareness. Great observations, Lisa, as
Mhm.
well. You said a few times that she longed to know that God was still saw her.
Mhm.
What does it look like for Lissy to know that God sees her?
Because she feels so unseen. I don't know. I don't know the depth, but I've met again, as I said, this is a fit visit, and this lament about invisibility. The doctors are not seeing her, and even like she said, something I couldn't put in there is the husband too doesn't see her in that, because she's been lamenting a lot. I think the husband is tired of that and doesn't see her pain, and how can you keep questioning God like that, so there's a sense of she wants to be seen, and not only seen, validated. She needs to be. That's why it was important for me to tell her, your anger, your pain, and all of this are a form of prayer, because it's faith seeking understanding. In that moment of the faith doesn't understand why I have faith, I'm going through that. And in that journey of faith seeking understanding, it laments, it's angry and all of that. I needed her to see that it's not only you are seen and validated, and that
How does she define being seen by God? I understand how you do and what you feel is helpful, but I'm not sure how she will know she's seen by God. So that would be my invitation,
right,
to invite
right.
her to articulate what that means to her, to be seen by God. What would that look like?
I think also because, again, in the summary, after this, we did our thing. We obviously, she always invite me to have tea with her in that non CPE moment. She was talking about how she's grateful that I said it is okay to be angry,
Mhm.
and that it's okay to question.
Mhm.
And I think that for that I really do think, even though she didn't say this is how I feel seen by God, I really think it means a lot in that if God can allow her to be angry, and that is a form of prayer, to lament, I think that is God sees her in her pain. Again, I am the one interpreting this, but
And
she kept saying,
that's what I'm
this
pointing out.
language of
Yeah.
the importance, that she kept saying, "Oh, thank you," and I, at least someone can be telling me that if I'm angry for God, it's okay, and that is prayer, that for her, because I think that she got pushed back a lot from that with her husband lately. Yeah, but again, I think it's a question to really ask as a follow-up, which is good. All of these peer reviews is important, because I can make that a follow-up.
Yeah.
Since she used that language a lot, I can use that a follow-up. So is there
Yes.
any way, for instance, that you felt this week like you felt seen by God?
There you
You
go.
know,
That's right.
yeah.
That and it is still an open-ended question. It's repeating back what she has, and I'm pushing that because I'm thinking about your goals. Like you said, hey, I need feedback here. That's one way, because you're right.
Right.
You don't know, you're interpreting. Here's an
Yes.
opportunity to have her tell you. And obviously when she does it, now you are wrestling together, and that's
Right.
powerful. So you're
I
inviting.
think that's very important. Thank you. I will do that next week in our follow-up visits, and that would be an important question because that's an important concern. She needs to be seen and validated.
What does that mean to her? Very good. Very good. Very good. I love your reflection and your questions, and that's why I wanted to try to respond to the many of them as I can. I made some notes, and I'll share those notes with you as well. Very good.
Thank you.
Thank you, Alice.
Yes, thank you.
Thank you, Marcelo.
Marcelo, would you like to go next?
Yes, please.
Have you nice and clear. While we have Marcelo nice and clear, would you all mind if we went straight to Marcelo without break?
No,
Okay.
that's fine.
Okay. All right, Marcelo. Let's see if we can do it. Are you? I don't think you can screen share, can you? You need me to do it, or you got it? Look at me. Look at me underestimating you. Go
Yeah.
ahead, Marcelo.
So I lost to Lisa.
I think Lisa popped out for a second. Let's see if she's trying to log back in. There she is.
My internet keeps going out. This is the second time it says it's unstable. I don't know why.
Okay.
Sorry about that.
So I'm ready. Chaplain student Marcelo Escárzaga, date 3/7/25. Verbatim is 4. I put 5, but it's 4.
So it's 5. You're right. It's 5.
Okay. Passion initial is AY, age 32 years old. Gender, family, primary support family. Diagnostics is preeclampsia. Race, ethnic, Hispanic. Religion, Catholic. Date of visit is 3/7/25. Location, Tipton, California. Clinical. Visit number 4. Okay, the part number 1, the answer number 1, the primary learning issues. I want to focus on his school to offer spiritual care and present to passion experience, emotional insulation and vulnerability, especially in case where medical complication, such and high risk pregnancies are combined with limited social support. My peers and certificate educators can help me by offering feedback on who approach to passion and what I mean have missed, sharing insight and who they have provide care in similar high emotion, low support situation, suggest resource or language that could be held when ministering to passion, experience, anxiety, loneliness, and family separation. I want to develop deeper skill in recognize nonverbal cues or emotional distress and healing provide and compassive and spiritual grounding present in silence, organic conversation. I have selected the following indicator. I want is IA2 articulate awareness up reflect of when a care encourage interacts with element of one narrative story. Indicator IA3 demonstrate and loneliness of one social identity of real to spiritual care. IA5 describe who one's value and belief about the spiritual care are part of the one's orient systems. Background: the patient is a young woman, pregnant and already a mother of the 4 children. She was admitted to the clinical or hospital due to complications related to pre- preeclampsia. Upon entering the room, I noticed she was alone. There were no flowers, card, or personal memories. But basically, the curtains were drawn and the light were dim, giving the room a somber and quiet atmosphere. I could sense a deep emotional when in space. Her husband, the only close relative, works long hours on the local dairy and was unable to be present with her during the day due to work obligation. This physical absence added to the patient emotional state. She was experiencing both depression and anxiety, intensified by the uncertainty of the health and the well-being of the under child. What brought me to this patient was a referral from a nurse who noticed the patient seemed with down, tearful, had expressed feeling of fear and isolation, has entered the room, approached with quiet respect and attentiveness. I could hear the stir piping of the monitors, the hinting on of the hospital equipment, and the occasional footstep in the hallway outside. Her vulnerability was palpable, and it was clear that she needed spiritual and emotional support during this difficult moment. Personal status, I was in calm state. I was mid-morning, and I feel physical and spiritual center after completing my prayers routine. I was prepared to be present for whatever the patient need emotional need. Emotionally, I feel a certain anticipation. The referral indicate possible depression and isolation, which led me to approach with compassionate curiosity rather than anxiety of reflection. I recognize that my previously experience with families in similar situation awakened in my genuine desire to accompany her spiritually. I didn't feel a personal pre- preference toward the patient whose clear calling to be present with empathy, silence, and attentive listening. My spiritual focus was on trusting in God present during this vulnerable moment in her life. Excuse me, pastoral plan. The purpose of my visit was to offer spiritual and emotional support to a young pregnant patient who had been referred to me by a nurse to sign of depression, fear, and isolation. I understood that she was facing a high-risk pregnancy, comply B preeclampsia, and that she spent most of the day alone with her husband working long hours. My role as a chaplain in this situation was to provide compassionate presence, attentive listening, and re- re- resources in the midst of the emotional and physical vulnerability. Pastoral visit record as much of the interaction as you can recall. On the left side of the page, document was saved. On the right side of the page, recording the parentheses and attitudes, judgments, feeling, assumption, or surfacing memories you recall present in the moment. Emotionally, uh, I feel calm and open, ready to convey support and respect. I was preparing to receive whatever the patient need to share without footmen with her available to accompany her through attentive presence and listening. So I need help in the C1 and AY.
So we're going to do the same thing. Marcelo, I want you to read the words of the patient, of the woman, And Alice and Lisa, if you would volunteer for the rest.
Okay.
I can do C1.
Okay, I'll do parentheses.
Okay. Thank you.
Good morning. I am the hospital chaplain student. My name is Marcelo. I just wanted to stop by and see how you are feeling today.
Hello. Thank you for coming. I am okay. I'm well, I guess.
Thank you for allowing me to be with you for a moment. Have you been able to get any rest?
No much. I can't just sleep well here. I think too much.
Do you like to share what you've been thinking about? I'm here to listen.
My children, I have four. They are young and I miss them. I feeling guilty for not being with them.
It must be very hard to be here knowing they are at home. Right now, you are doing the best you can, taking care of your health and the baby that's on the way.
Yes, but I also worry about my husband. He works all day of the daily. He cannot come often, and I understand, but I feel very alone.
In the middle of our conversation, there was a brief pause as one of the patient's daughters entered the room. She came only to drop off some fruit for her mother and quickly left. It was a short one.
I can imagine how lonely that must be. Does it help to talk about it out loud, to share it with someone?
Yes, I feel a bit relieved just having someone else here who listening.
That's what I'm here for. Would you like us to pray together?
Yes, please. I think that would help.
Merciful God, we ask that you stay close to your daughter during this time of uncertainty. Fill her with peace, strength, and hope. Bless her baby and take care of her family. Amen.
Thank you. I needed that. I feel a little more at pay and peace.
Okay.
Thank you, Alice and Lisa. Five.
So I'm gonna flip it a little bit more, Marcelo.
Mhm.
I'm gonna ask you to stop sharing your screen, and I'm gonna invite us into reflection, just having read the verbatim with you, the dialogue part. Okay.
Okay.
So please, Alice and Lisa, let's offer Marcelo some feedback and dialogue, and we can keep in mind his learning needs, what he identified in the beginning.
I would say that, Marcelo, I really like that you are bringing in a lot of conversation in your verbatim, which is really, really good. I like that. I like the way you set it up. I like the way the conversation is progressing. I like it also. But one thing, there was a sharp shift between, I don't remember, I think that is AY10. But between your question, will you want to say, to share aloud? I want to read this particular one. I don't.
You want him to share the screen again?
Sure.
Yeah, if you don't mind, I'm sorry about that.
That's okay. This is why we number it, so we can be specific.
Do you, do you
Okay.
see?
Yes, you said C. Let's go to C9. I can
Okay.
imagine how lonely. I can imagine how lonely that must feel. Does it help to talk about it out loud, to share it with someone? Then 10 say, yes, I feel a bit relieved just having someone here who listens. Then the sharp shift, which is moved away from the conversation, is that's why I'm here. Would you like us to pray? You've just asked her if she wanted to speak out loud. There's no conversation. You can give her that opportunity. She said, yeah, that's that she's happy that someone is here to listen, and you did not. You just went straight to pray. So it was the reason, or did you cut out that conversation out? You might have had the conversation and cut it out in your report, but the way it is right now is the shift is too sharp. There is no, you just invited her. That is a missed opportunity because she didn't get that opportunity to share, because she says, I feel a bit relieved just having someone here who listens. Then you move to prayer. Did you cut that out, Marcelo? The conversation out? Because I'm sure you gave her opportunity to speak it out loud as you invited her.
Do you understand the question, Marcelo?
Yes, yes, yes. Uh, Thank you, Alice. It's true. The conversation is important. So stay more time with this person is important because she stay alone for long time, you know. So uh, I think in my intervention is no good.
I think no good might be a little uh, hard on yourself. I don't know that you would say it's no good, but yeah.
Okay. I was just gonna say what I got from it is the conversation that he had previously. That's where he was telling her, does it help to talk about it out loud? Did it help her, to talk about it out loud and to share it with someone? That's what I felt that it meant.
Oh, okay. You meant you understood C9 as a summarizing of what came before?
Yeah, what came before. That's what I thought it was. Because she talked about being lonely, she didn't have her children and all that stuff. And then he was asking her, did it help to say, I mean, that's what I got from it. Did it help
Yeah.
for her to share that out loud? Did she feel better about it?
Okay,
I think
okay.
both of you are right. It's not either or, it's both and. So C11, which we always talk about how it might not have everything, that's what I'm here for. Could be followed with, is there any more thing else you'd like to talk about? As opposed to, would you like us to pray together? Which shifts to a task, prayer. Because my hunch is in your orienting system, prayer is very important. And in what you understand your role to be as a chaplain, prayer is very important. So you're trying to get to the task. So I think both observations of Alice and Lisa are helpful. More conversation is okay. Anything else you'd like to talk about? Right. And clearly prayer was something she welcomed too. So I also want to affirm, I love that you asked her, would you like us to pray together?
And the way it concludes, I think P14 simply is AY14, right?
Yes.
Yeah, that I feel a little more at peace.
Yeah.
Thank you. I needed that. I feel a little more at peace. Okay. That also shows the rest. She appreciated
A prayer.
the Marcelo's prayer. Yeah.
And Marcelo, I understand you're working with the language, and I can only imagine how vulnerable it might be to ask someone, what do they want to pray for? Because then you're going to feel compelled to try to understand what they've said and maybe to then pray for that. And that's got to be really hard while you're simultaneously trying to make sure you understand what they're saying. But it is a different prayer experience to ask someone what do they want to pray for, not just you want me to pray over you. Because although you're saying pray together, and she clearly did, you're doing all the praying. In the sense that, I'm not saying she's not praying, let me restate that. In the sense that you give all the words and the inputs to the prayer. She doesn't add words and inputs to the prayer. I understand that's got to be a very vulnerable place to be.
Yeah. So this is thank you, Donna, and Lisa. This is a very current situation in my business.
Let's stop your screen
Uh,
share.
uh,
Your power.
okay. You can hear me?
Say it again.
Oh, wait, wait. You can hear me? Hello?
I
You
hear
can
you
hear
now
me?
clearly. We can hear you now clearly.
Oh, okay. Thank you. Okay. This is very recurrent situation in my visit. It, it, it is very obvious for me because my English is poor. So usually I'm I'm explaining to Donna that I visit, I'm preparing to pray and we pray. So
We we
I
can hear you clearly now.
that is hello. You can hear me now?
Does it seem like he's frozen?
Yeah, it's frozen.
Yeah.
I think.
Mhm. Maybe he should turn his screen off. I mean, yeah.
That's a good idea. Marcelo, you want to turn your screen off again? And maybe we'll hear you better.
Yes, yes. So you can hear me?
Yes.
Okay. So um, this is a very recurrent situation in my visit. Uh, it is very obvious for me because my English is poor. So usually I have the structure to the visit. So my limitation in English is because um, I got to the interview or to the meet with the patient. You understand?
No.
And
Okay. There's a lot of parallels between your verbatim Alice and Marcelo's verbatim in that how are you present with someone who's isolated and suffering and I bet his phone has got to be hot by now. This is a few hours on the phone.
Did you see the message he sent?
No, ma'am, thank you. God, it's very obvious to me. That's great. I'm glad he appreciates that. Great. So I I appreciate both your feedback to him too, because I think that helps to be able to hear it. I also think his goal of open-ended questions is helpful. Can any of you, can either Alice and Lisa, can you look at the dialogue, or do I need to put it on the screen, and think of some open-ended questions, or just recall some parts where you could say, here's where you could ask an open-ended question.
Yeah, you gonna put it on the screen,
You need me to put it on the screen?
please?
Sure.
You're welcome, Marcelo.
You did fantastic, Marcelo. Thank you.
Oh, wow, that was amazing that I could find it. Okay. Can you see it? Let me go to one page.
Can you make it larger?
Mhm. So Marcelo, we're going to share with you some open-ended questions that come to mind. That wasn't C5 was great. What are you thinking about?
Mm-hmm.
C7, you made a statement that repeated and summarized what she said, which is a wonderful way for someone to feel heard. It must be hard to be here knowing they are at home. And you could pause before you make the judgment. Right now, you're doing the best you can, taking care of your health, which is a judgment statement to her. You could just pause. And just with that statement that you made, it must be very hard. And then she's like, yeah, I also worry about my husband. She's got a lot on her mind.
Isn't what women do?
Mm.
Not sure if they do same.
What do you think of C9?
Maybe
I love
how can you find
C9.
how can you find peace in in your loneliness?
Oh, wow. Okay. It's a similar thing, C9 as C7. And again, we know there's limitations to capturing the dialogue. So I can imagine how lonely that must feel. Stop. Just be in the silence and see what she says. If she doesn't say anything, you can say, do you want to say more about that? Or I just say more about that, whatever style works for you. That's another open-ended invitation. And I agree, C9, C7, both wonderful. We're just responding to Marcelo's requests in terms of things he wanted to learn and that he wants to try in the next visit. If she had said no, it doesn't help at all, that would have been a hard moment for the chaplain.
Does that often happen?
I don't know. It certainly has happened to me, but I don't know how often it happens to, like in a general sense. But it has happened. I would say maybe in a 2% of the time, and then usually it leads to a moment of laughter, or yeah, laughter. I acknowledge that. I mean, say something like, "Okay, that just shut the chaplain down," and then we'll have a moment of laughter, and they'll continue talking. They'll go from there. So any other, it's again, we know it's difficult. We acknowledge what you have said, Marcelo, in the chat. Good job. Okay, do we need a break or do we want to go straight to police?
I unfortunately have to pick up my daughter today, so I need to leave like 2:40.
Okay, well then why don't we
She's
keep going so
yeah,
you can get as much as you can? Is that
yeah,
okay? All right.
absolutely. If Lisa is okay.
Mhm.
Good job, Marcelo. Good job.
You ready for me to share?
Yes, ma'am.
Oh. Now mine's kind of lengthy. If y'all want me to skip over some stuff, tell me, I will. Mm. Ooh.
You know you don't have to read the outcomes, that part.
Okay.
You can start with why you brought this one.
Okay. I'm presenting this verbatim to demonstrate that I can now actually assess and identify the intervention provided to the care recipient. I'm feeling more confident about this process and asking the right questions to help the care recipient connect spiritually with their sacred source. What is the learning issue? I want to confirm that I'm asking the right questions during this assessment and offering the correct intervention. How can your peers, they can help me by listening to this verbatim, taking notes on what stands out as something that I might need to address, add, or change, and give honest feedback. The indicators are
Go to background.
Go to background. Oh, you said not to do that. Okay. BB called with concerns about her 87-year-old mother who may have dementia. Plus, BB believes that she has some mental issues. Her mom lives about 6 hours from her. She has a
Oh.
brother and sister in the same town as her mom and currently lives alone. The brother goes daily to see their mom, but is often verbally abused. They're unaware of how much longer she can live by herself. She refuses to receive any medical care, including dental care. She has money, but holds onto it and will not spend it. She was found unresponsive at the end of February by a neighbor and rushed to the hospital with some infection. But once discharged, she didn't do any follow-up care that was instructed by her doctor. The mom is extremely mean-tempered and has nothing nice to say to anyone. Her mother's symptoms have worsened over the last few months. She will hide her purse and say someone broke in and stole it. She accuses people of coming in her house and rearranging the furniture and eating all her food. The list goes on. BB calls her mom twice a week, but over the last 6 months, her mom will not answer the phone, or if she does, she's verbally abusive, then accuses BB of not calling her for weeks, and she will visit her mom next month and is worried about how that will go. I was tired. I had gotten home from a visit, had a phone conversation with another church member. However, I felt like I could take one more call. Um, when I saw the number, I knew who it was and anticipated it was about her husband who had just had surgery. The goal was to assess the need. The plan was to ask how I could best support her spiritually. I would instill hope so that she might find peace to get through. I would make empathetic statements after the conversation began. I had to switch up because she was calling about her mom. So need somebody to be the chaplain in parentheses.
Alice, would you be the chaplain? And Lisa's going to be.
Yes, I can.
And do read the parentheses as well, Alice.
Okay, no problem. Hello, how are you doing today? I'm debating whether I did have the capacity for this phone conversation after all.
Hey, Chica Moore, what are you doing?
I should read that too?
Yes.
Oh, okay, no problem. She sounded pretty happy, so maybe everything was all right with her husband. I'm not doing much. How is your husband doing? I was hoping that there wasn't a setback.
He's doing great. He's actually outside cutting grass.
She sounded happy and relieved about the outcome of the surgery. She chatted for a bit, then she changed the subject to her mom.
You're not
You're
gonna
not going.
Is that me or you? Which one is it? It's
Oh,
me,
it's
right?
you. It's
I
you.
think it's me.
Sorry.
That's okay. You're not gonna believe this. I called my mom and she let the phone ring and ring. And when she finally answered, she screams at me. She says, "I'm trying to get dressed. Leave me alone." Then she hung up the phone. I thought maybe she just laid it down. No, she hung up on me.
She screamed at you. How did that make you feel? I was feeling bad for her. I know that she has tried to make this relationship work.
Yes, my mom is really mean and has a hateful attitude. I know how she is, and I try to deal with it the best way I can. I know that she has some dementia. She's been hateful my entire life. She is not nurturing, and she never really showed love toward any of her children.
She didn't seem frustrated. I was frustrated by how her mom was treating her. Her experiences counter-transference. I know this is not me or my mom, so I moved on. I am genuinely, okay. I'm genuinely sorry you have endured this for so long. May I ask you a question? After I asked, I was nervous she might say no.
You know you can, Chica.
What gave your life meaning in the past and even now to cope with your relationship and not having a nurturing mom? I feel uneasy asking this question. She didn't seem to mind.
I've always gravitated toward older Black women who taught me about life and nurture. My grandmother also provided me with nurturing care and showed me how to garden, which brings me peace. I can't believe my mom was her daughter. They were nothing alike.
I remained silent to see if she had anything else that she wanted to say.
My father must have known that my mom had mental illness. We always had a housekeeper. I believe now, as an adult, that he knew she couldn't care for us kids.
You said that you found yourself leaning towards older Black women. What has that been like for you?
Yes, at one time I was best friends with an older Black lady when I worked at Belk. We did everything together. It was one of my best friendships. She has died, but I still have the great memories. I also attended a predominantly Black college. That was a great time in my life.
She seemed to have a lighter tone as she spoke about her memories. What gave you the capacity to be so resilient?
I didn't do it on my own. I believe God guided me in their path. I have friendships that have helped me along the way. I have a group of ladies in my community that I meet for breakfast every week. And we also get a pedicure together. My husband and I also have another group we meet with for supper on Fridays. And I can always call you because you're a pastor.
I waited to see if anything else came up for her. I was reaching my limit. I was getting tired. At the same time, I'm grateful that she calls me for help.
My mom didn't have any friends. She never knew how to be a friend. She always had something negative or mean to say about people.
I didn't have a lot of friends in my childhood. This triggered me. I felt some countertransference and I felt empathy for the mom. I'm so sorry to hear that. Living alone without friends can be a challenging experience.
She brought it on herself. One lady used to give my mom gifts and food. She cared for my mom, but my mom only cared about what the woman was bringing. And when the woman died, I asked my mom if she wanted to go get her me to find a way for her to go to the funeral. And she said no, she only missed what the woman brought, not the woman. Well, I need to get off now. Thank you for listening. Keep me in your prayers.
Do you want to pray with do you want me to pray with you now? I knew that she wouldn't.
No, no, which I spelled it wrong. No, when you do your nightly prayers, goodbye, Chica. It was great talking with you. Thank, thank you. Um, do you want me to continue on?
Yes, please.
Okay. She has stated that her mother is mentally ill and may have dementia, but a doctor has not diagnosed that. She, she also stated that her mother has never called her or her siblings and wished them a happy birthday. It seems like she's having a hard time with her mother's verbal abuse. I believe the situation is starting to overwhelm her because she lives so far away and she wants to help her brother but cannot. What are your emotional concerns? Vivi uses her friendships and God to cope with the absence of loving, caring mom. For the most part, I believe that she's getting what she needs because she knows how to ask for help. And her girlfriends and surrogate families support her. What feelings are expressed. It wasn't in the write-up. However, she was worried about her brother as well. He doesn't cope well with the abuse or how she embarrasses him when he takes her to the grocery store or to the bank. She feels like her brother is on the verge of a heart attack because every time he visits his mom, his blood pressure goes up drastically. My own emotional state is good. I was hungry because it was past my usual eating time. I was also tired because the visits and the phone calls had been a long day. I like the person. She's not a church member. She doesn't attend church. However, she does talk about God a great deal. She knows that He will take care of her. She knows I'm a pastor and can call whenever she needs spiritual care. I believe this is one of my better verbatims. I could do the spiritual. I could. I could do the spiritual assessment and ask open-ended questions. Um, I slowed down and implemented active listening. And did not rush over the conversation. I did not interject my mother-daughter issues. However, I did share with her that I have had mother issues in my life at one point. I didn't take over the conversation. I wanted to acknowledge that I heard her. Mother-daughter conversations trigger me to some degree. However, I could pay attention to my emotions and body, and I knew this was not about me and my mom. I had to remind myself that my mom and I were well, and that that doesn't mean I'm not still triggered. How might I respond differently? C10, I wonder how I might have asked this in a more meaningful way. What gives your life meaning in the past and even now to cope with your relationship? Um, I feel like I could have asked that maybe a little differently. And C18, I'm sorry to hear that living alone without friends can be a challenging experience, because her response made me think I might maybe went too far. She said, well, she brought it on herself.
Hmm.
Um, what did you learn about yourself? I have more self-awareness. I'm learning that I don't have to fix the situation. All I need to do is listen and help the care recipient connect to their sacred source. I've learned that even if the care recipient triggers me, I'm learning how to regulate my emotions, understanding that I'm experiencing countertransference. I found that I can be a spiritual resource for my care recipients when they need hot food or groceries or whatever. Where we used to work together about 7 years ago. Um, and I thought we would discuss her husband's health, but it ended up being her mom's. I assessed that the person needed me to use my active listening skills. I gave her the space to talk. I remained silent when necessary. She never said, are you still there? Some people will ask, if you're still there, they're uncomfortable with the silence. I helped her connect um, her sacred source, including her faith in God, friendships, and gardening. I was a non-anxious presence, reflective listening. C13. You said that you found yourself leaning toward other Black women. What's that been like for you? She screamed at you. How did that make you feel? Open-ended question. What gave your life meaning in the past and even now? Um, and what gave you the capacity to be so resilient? Intervention, I was a non-anxious presence. I listened, I held space. I acknowledged the grief that I heard in her voice and the pain of not having a caring mom. I also told her that I would follow up and see how she was doing. I came alongside her, acknowledged her pain. Um, Reflecting on theology, my faith was challenged by the care recipient's mother's lack of ability to give her children what they needed. She had a mother who struggled with nurturing. I had a mother who failed in other ways. My experience was quite different from hers. I can relate to some level. I look at some of the mothers in the Bible, and it didn't say much about mothers who were not nurturers. One thing that did stand out to me, 1 Kings 3:16-21, where the women fought over the baby and the judge said, cut it in two. And the real mother said, no, give it to the baby, give it to the baby to the lady. She had stole the baby and then she said, kill it. Why do some mothers not have the gift or skills? Is it something that should be automatic or is it learned over time? God has never promised the road would be easy. However, he said that he would always be with us. God gave BB what she needed through the care of other women. As far as having the instinct to nurture, I don't have an answer for that. I was a nurturer for my son because I had been an aunt to my nephew who lived with us for 7 years before my son was born. I had previously lived on an Air Force base serving as a community babysitter to a diverse population. When I left, some of the mothers cried. 1 Corinthians 16:14. Let all that you do be done in love. We may not get everything we need from our birth families, but God will give us the love that we long for through you know what I mean? That's through a faithful community. Um, Ethical and social justice. I feel like the mom may need additional attention. She does not eat well. She's possibly has dementia, but no medical care. When found responsive, it was noted that she had not bathed or combed her hair. The family appears to be in denial about her ability to act, their ability to act because of how violent she has become. My care plan is to listen and not be anxious, and I will follow up next week. I will continue to support her by listening. She seemed to be in a better place when we got off the phone. I think that's it.
Good. Can you, before you stop sharing, go back to C8?
Uh, um,
I love your, I'm jumping in, I apologize. I love your awareness and your curiosity around countertransference.
thank you.
And in P7, you're like, I was experiencing countertransference. I know this is not me or my mom, so I move on. Is there anything in the countertransference that you were experiencing that might have directed you how to stay present as opposed to only move on? And if you need me to ask that better, I can.
Yeah, if you can ask it a little differently.
Okay. So your mom was really mean and had a hateful attitude. She was
Mhm.
7. And you're like, I got some things. Then she was hateful her entire life, that she wasn't nurturing. She didn't seem frustrated, but you were frustrated by how her mom was treating her.
Mm.
But you said, hey, this is countertransference. This
Mhm.
ain't, let me move on. I'm wondering if the countertransference and moving on might have caused you to miss the moment to invite her to reflect on how she felt.
Yeah, possibly. Yeah, because I moved on because I felt like I was going to interject something, and I didn't know if it was appropriate because I didn't want to make it about me, you know.
Very good. That's exactly what I'm feeling. So I want to invite you that the powerful self-awareness, wait a minute, this isn't my mom, this is hers, is excellent. And it's okay to say that must have been hurtful. Or was that hurtful? You could just inquire. So
Okay.
clear this is me. Or maybe it's just me and not her. How did you know? So that the counter transference informs you. It's not just, oops, there it is. Let me get out of here. It's
Right.
like, oops, there it is. Let me be curious
Okay.
with no investment, no
Okay.
judgment. So if she says, no, I'm fine. You like, okay, now my counter transfers. But if she doesn't, then she explores it. But you have no judgment, but you let it
Okay.
inform you. Very good. But I love it. You were like, look, I'm sorry this has happened for you. How did you manage it so long? I was like, ooh, you like, I'm out. Then you got, look, let me ask you another question. And you, so great self-awareness, that's excellent. And now the tricky part is, how do you let it inform you to hang in there? Very good.
Right.
Very good. Okay, I'll shut up. Alice, Marcelo. Great, great
You
work.
want me to you want me to take it down, or you want me to leave it up?
Alice, you need it up or down?
No, really. Wait, am I echoing?
You are.
Do I still echo?
No.
Oh, okay. I was just laughing. This is one terrific conversation that was just making me laugh. Also, you in the end, you want to ask for prayer, and you knew she would say no, and she said no. You know. So yeah, I really love it. I really honestly love it. And the follow-up question, like Donna is saying, the realization, a lot of time you hesitated asking questions. And I'm curious about that. You ask, but you at the end you say, I would, you really hesitate a lot asking questions. Is there something much more than just
You asked me why I hesitate.
Mhm, mhm.
Um, I guess it's I worry about, am I gonna say something that's gonna hurt somebody? or is it going to help them? I don't want to cause harm. I don't, I'm learning more and more as I'm in this class, what type of questions to ask and how to ask. But I really felt unsure before, you know what I mean, to ask those questions because, you know, I don't know. I think I was maybe too cautious, but now I see the questions that everybody's asking, and now I feel like I can ask the question and not cause harm. And if it does, I'm sure they'll correct me. And it's okay if they do. I have to be ready for that and not be offended by it.
Overall, I think it was terrific, honestly, terrific.
Thank you. I appreciate it.
So, Lisa, you can hear me?
I hear you, Marcella.
Okay, thank you. I have a question about this case. Um, those baby mother um, have a confirmation diagnostic of dementia, or it is just one uh, baby believers?
Yeah, it's her brother and her just believe by her behavior and her actions that she has, dementia, because she like, put the purse somewhere and forget about where it is or hide it and, say somebody came in and stole it or whatever, and they'll go in the bedroom, it's in the bedroom, or sometimes she even have it around the neck, or something. It's just different things like that. Or she forget to eat, she won't eat and stuff like that, or take a bath. So they feel like she might have, dementia.
Okay, thank you so much. So, other comment, I would like your hair.
Hmm?
I would like your hair, your style.
Oh, thank you, Marcelo. You caught me off guard. I was like, what?
Good job.
Thank you. I appreciate it. That was very kind of you.
Donna, you and myself, we need to go get Lisa's hair so that Marcelo can appreciate it.
I want to follow up on Marcelo's first comment. I think you identified well in the ethical and social justice issues, which sometimes you skip, but you did it well. The senior isolation, she's 87 years old, she lives alone. That's a social justice issue, particularly unique to quote unquote Western cultures and how
Mhm.
we treat our seniors, and this notion of individualism. People have pride in being alone, but when you become a senior, there's ethical and justice challenges with that. Very good. And the demonstrated signs, not attending to her daily needs, forgetting to eat, the memory loss, that raises the concern of dementia, but the acknowledgement of the lack of financial resources or medical care to explore that. When the emergency room is your doctor's office, so she went because she was forced to go because they took her when she was unresponsive. You don't have good medical care in terms of preventive care
Right.
or someone who's going to inquire beyond the emergent situation. Because
Right.
clearly, a primary care doctor that's giving regular visits is going to do that assessment. And then you determine whether or not they're competent to be alone. And then you need lawyers and care, and it's a lot. So thank you
Right.
for identifying those social justice issues and the possible weight of that. I love your sharing with us. Hey, it's hard for me to ask questions, and I'm learning how to ask them. And I just appreciate that and appreciate you taking the risk to ask that question about, how she did with that. That was very risky and well done. Your assessment, intervention language, you're like, boom, I got it. And now you have another goal of how you're going to let your countertransference inform you. Well done. Well done. Well done.
Thank you.
I thought I was on mute. I apologize because I was laughing thinking I was on mute because it really was, as Alice said, it was kind of funny to observe as we were from a distance. I thank you all for letting me flip the switch a little bit on us. As you can tell, when you have to read the care recipients part, it's a different experience for you. And I don't begin there because I don't want you to be preoccupied with that. I want you to be preoccupied with you in your verbatims. But this was different. You got to hear your capturing of their words out of your mouth, and we also got to experience it.
Right.
Thank you for doing that. I think our verbatim journey is one of everyone getting stronger as we have progressed. All of the verbatims have just grown as we've gone along. So well done to everyone. Well done to everyone. I'm going to steal a few moments. If there are no other comments for Lisa, I did sort of close this without asking. Are there any other? I'm going to steal a few moments, then thank you. Thank you, Lisa, to share this piece very quickly. I think this is the right document. And it's just some observations that kind of come particularly from Alice and Marcelo's verbatim, but it also, I think, has some things that would be helpful and is informed also by yours, Lisa. So, I read them before. So obviously I couldn't have notes if I didn't. So each of you are talking about open-ended questions. So I just want to reinforce how open-ended questions can really invite somebody, especially dealing with prolonged suffering and chronic illness, to explore things like meaning and purpose. So there's some examples. What gives you strength or meaning during this time? How has this experience shaped your understanding of your purpose? Addressing emotional and spiritual needs, those open-ended questions. What emotions are you carrying with you today? Sometimes when I'm doing repeat visits and I ask, what emotions are you carrying today? The person who every time I came was carrying lament and anger, lament and anger, lament and anger. When they have to hear themselves keep saying the same thing, I notice then they are pushed to kind of discover something else. And I'm very specific today because they're in a long journey and I'm not trying to minimize all of the emotional and spiritual needs they have. Are there any spiritual practices or beliefs that bring you comfort? And Alice wanted to know, what are some rituals I can do to help her? She may know. So asking her, I think your tea time is still pastoral care time. And I think that tea time after is very important to her, Alice. And you're already participating in a ritual that's bringing her some healing. But I know you haven't had a chance to reflect on it here. Does that make sense to you, Alice? Okay. Encouraging reflection. What has this journey taught you about yourself? Are there moments of peace or joy that stand out to you? That's a risky one, but it can be so helpful. Again, you're making the person think. Who or what helps you feel most supported right now? Right? How can I or others best walk alongside you in this? Often you get the answer to that in just the course of the conversation. What hopes or goals do you hold on to, even in small ways? Sometimes when people are in prolonged suffering or in difficult situations, we don't want to ask them about hope because we're afraid they don't have any hope. What has helped you endure challenges in the past? It's a way of, quote, mapping a person's assets by having them remember what's helped them in the past because it may help them now. But if you just say what helped you before can help you now, what is it? Well, that's not the way to go at that. So you just kind of say what's helped you in the past, endure challenges, and they might begin to map their own assets. So you're just creating space and you're doing it without judgment. We experience today in the verbatim how powerful superlative questions are, meaning when you say, what's the best, what's the worst, what's most or least, it creates this dynamic of reflection and comparison, which can be so helpful when I'm lamenting, but it also creates this dynamic of storytelling, which can be so healing when I'm in prolonged suffering. I can begin to tell stories. And so the person begins to shift into this evaluating of their experiences. And it just shifts the atmosphere often, not always, often to deeper conversations and insights. Superlatives questions encourage reflection, right? I got to think what was most valuable lesson I learned. What was, it makes me sort of go into a different place. Superlative questions can foster connection. Who is the most inspiring person you know? None of you seem to have problems with connections, though. Not problems, but you all seem to be connecting very well. Stimulating engagement, questions that can sometimes spark engagement, like, what is the best part of what you are experiencing? It's also a very frightening question because we don't want to ask somebody who's suffering, what is the best part of it? And sometimes it may be you, that you come to see me. And then that adds, another weight on you, but that would be good to know. And then all of you enter the room and enter conversations very well, but if you're ever challenged, superlative questions can, as they say, break the ice. Last few comments about lament. Inviting people to lament, as you know, is that creating a space, that compassionate space where they feel heard. You do this very well, where you normalize their lament. You normalize it as natural. You point out that it's valid. If you can connect it with other stories of lament in scripture, it's helpful. I couldn't help but think like you, Alice, of Jacob, when you were talking about the spiritual crisis and wrestling. Provide a framework that helps someone lament. Give them some guidance on how to lament. Invite them. You have a journal. You've taken this psalm and turned it into a prayer. Do you want to turn it into poetry or art, or does an image come to mind, or a color? Just you're inviting them to process through different senses in their body and different parts of their mind. Ritual ceremonies, again, I ask them, but I try to keep some handy too, but I ask them what works for them. Storytelling, I already talked about that. Music, poetry, you all very well create a safe space. Again, that's a part of inviting one into lament. And then prayers. One that we sometimes can readily do is breathing. When we invite a person into a breathing exercise with us, what is it, 4-7? Can't believe I just lost the numbers, but it's just a breathing exercise where in essence, they exhale longer than they inhale. It ignites the vagus nerve and it causes the body to begin to relax. So a breathing exercise. And then just acknowledging hope amid pain, that they coexist. And it's so important. It's not either or, they can coexist. I want to caution all of you to describe, but not diagnose. So when we use words like she is depressed, that's one thing. And that's one way to describe it, but we want to be very careful that we focus on describing the behavior we're seeing, and as much as possible, stay away from clinical labels or stay away from diagnosing. So it's actually more information when you say something like, it seems like you have depression. Well, I would prefer you say, you mentioned you're feeling down, or you mentioned that you're struggling with hope. as opposed to even using the depression language. They may use it and I may express curiosity, but I try not to initiate using clinical language. And I try to lean heavily on description. I will send this to you, because leaning heavily on description helps me be present. If I have to describe what I see, describe what I hear, describe what I smell, describe what I feel, it helps me be present in the moment. And just a blanket term of depression or anxiety. They have anxiety. Whoa, what am I seeing, hearing, feeling that is triggering that language in me? I want to lean into describing what I'm experiencing in a way from a broad term like anxiety, depression. Again, in the moment, it forces me to be present. And then it adds to my potential open-ended question. Wow, I heard you say you're feeling really low. Can you say more about that? As opposed to, wow, she just said she's feeling low, she's depressed, and then I move on. So by focusing on describing things, it also opens places for me to have open-ended questions. Okay. Okay, I want to share my little notes with you. I'm going to reach out to our presenter today, ask for the slides, and I'm going to pull out those 2 pages for the evaluation and send those as well. Just give me a little time to put it all together and send it to you. Any questions or comments or closing thoughts? You did a lot today.
Just so I understand, we don't have class next week. Then the week coming up, it will be when I'm not here. What is happening in that class again?
You're right. We don't have class next week. That's our spring break.
Right.
The
It's 25, 25th, the last class.
The 18th, next week, a week from today, we don't have class. We're on spring break, but you're
Okay.
still doing clinical hours. And then the next time we meet is April 25th. Alice will not be here. Our presenter is coming to talk to us about trauma-informed care.
Oh, okay. Yeah.
We have a movie that we watch, but it's in class, so you don't have to worry about watching it before.
I think Marcella asked, was the 25th the last class?
The 25th is not the last class because remember on May 2nd, you're going to do that final evaluation.
Yeah, but the May 2nd is we presented to the final evaluation, right?
Correct.
Yeah.
And then we meet again on May 9th.
Okay.
And then May 14th, which is a Wednesday, is the graduation.
In what place? It's in
Virtual. It will be, thank you. That's a great question. It'll be Joseph's virtual Zoom link, the one you use for orientation. And it's
okay.
on the front page of your syllabus. It's the first one. It's
Okay.
Joseph's Zoom link. We'll all go there. I imagine Joseph's going to send an email reminder between now and then, but that's a great question. Thank you. So the last time we'll meet as a group is May 9th.
Yeah, very nice. Okay, gotcha.
Can I ask a question? Do you know when we're gonna meet for the next class? Do you know the time or not yet? For the next
summer?
the next unit, I meant to say. I'm sorry.
Summer. Yeah, no, you're right. For the summer session.
I
I
received,
go ahead.
excuse me, I received the email to the Joseph. I think it started in May 17. It started in
No.
May.
It's May 20 something.
It is.
May 27th or something.
So what I can do is send Joseph an email and get both the start time, because I think it has been settled,
Okay.
the dates, and I'll put that in the information that I send to you. But to answer your question, Lisa, I don't know, but I did pitch that it needs to be um
I
Thursday.
check my email this night. I sent to all this email what is the exactly day because I received information for Joseph
Oh,
what
okay.
day is. Yeah,
Okay. You checked
Can
your
you,
email?
yeah. I check my. Let me check my email for.
Okay.
Donna, can you repeat what you were gonna say?
I I did share feedback to Joseph that our preferences was that we would meet either Thursday. I think it was at the time it was Wednesday, Thursday, or Friday, but we took Thursday out because that didn't work for you, Lisa. But it turns out that does work for you. And so I think I narrowed it down to we really wanted to be on Thursday. That would help me
Yeah,
because I have so much on Friday.
right.
So I just pulled up CPE of Central California's schedule, and the summer session begins May 27th through August 15th.
Okay.
So Marcelo, it may be a typo in whatever email you got. May 27th through August 15th.
Yeah, it's actually it's May 27 and finish in August 15.
You got it. All right.
Thank
So
you.
you're welcome. So give me a moment to put all that together and send it to you. And I won't have the slides. I'll send Dr. Thank You today, but I won't have her slides yet. But as soon as I get them, I'll send them to you. But I'm going to send you the little notes from the verbatims. I'm going to reach out to Joseph to see if I can get the time for the summer session. And I'm going to send you the final evaluation taken out of the handbook, and I'll fill in the first part.
Thank you.
Anything else I need to
Thank
do?
you so much.
You guys
Mm-mm.
have done very well. It was a busy day. You were engaged all the way through, and I am so grateful for you and your work. It's a good journey. I don't think we need an IPG.
Mm.
I think we need a bye-bye.
Yes.
All right.
Yes.
Have a wonderful weekend.
Send to
Bye.
you. See you, everyone.
Take care.
Bye.
Bye.